Hello, everyone. Welcome to our two-day scientific workshop on addressing the influence of interpersonal biases on health outcomes and disparities. I'm Carlos Garrido, and I'm the chair of this event. It is my great pleasure to kick off what promises to be an engaging and enlightening experience. We are thrilled to have a remarkable lineup of distinguished speakers, each bringing their unique expertise and insights to the table. So thank you for being here. So first, let me tell you about the workshop objectives, which is first, to bring together subject matter experts to enhance the understanding of mechanisms and pathways linking bias exposure to adverse health conditions and disparities, to inform about the current state of the science and identify research gaps and opportunities, and to strategize about future research directions that elucidate the etiological processes and multi-level interventions. So a little bit of a background about the nature of interpersonal biases. Interpersonal biases are implicit and explicit attitudes and stereotypes that people form about others, leading to discrimination. So implicit means automatic, occurring unconsciously, and explicit means conscious. So people can harbor biases against a multitude of groups, including based on race, ethnicity, socioeconomic status, sexual and gender minorities, etc. Evidence consistently shows that collectively, interpersonal biases are associated with detrimental health and well-being. So the following represents the cognitive perceptual processes leading from interpersonal biases to discrimination, which begins once a perceiver categorizes a person based on their social group. Once social categorization occurs, stereotypes are activated automatically. Oftentimes, this stereotype activation leads to stereotype application, which may lead to conscious or unconscious attitudinal attributions and downstream behavioral outcomes, including discrimination. So I wanted to share some background information here on what's out there in the literature. So modern day explanations for the biased health link underscore the role of structural factors, such as unequal access to healthcare or decision-making processes in clinical settings, such as unequal quality of care. But disparities remain after accounting for these differences. So a multidisciplinary approach is needed to address these gaps and move the science forward. Evidence in this emerging field is also limited by a dearth of mechanistic, longitudinal, and epidemiological studies assessing the role of cognitive perceptual factors, including threat and vigilance, physiological reactivity, including inflammation and accelerated aging, on health outcomes rising from bias exposure. There's also a debate about how to properly measure interpersonal biases, as existing research tools present some psychometric challenges. There's also a lack of interdisciplinary interventions aiming to reduce interpersonal biases and their expression, or interventions aiming to mitigate the influence of bias exposure on health outcomes. So here are some key overarching questions that I want you to think about when you present. So what are the most important research questions about interpersonal biases in relation to health disparities that must be answered to expand our understanding and move the science forward? What are the challenges? What are the opportunities for scientific advancement in the field of interpersonal biases in health? And what are the most critical gaps in our current understanding of how biases affect health? And how can future research address these gaps? A few meeting expectations here. Through this experience, we will enhance each other's understandings of how interpersonal biases impact health and health disparities. Share multidisciplinary, unique approaches to understand the complex interplay of interpersonal biases with other social determinants of health, leading to health disparities. Share and discuss tools, data sets, and best practices, overcoming common challenges and other approaches to address these gaps in the field. Where available, share preliminary research findings. Participate in discussions actively. We want to hear from you all, and your thoughts are critical to the success of this workshop. So to this end, please attend as much of the workshop as your availability permits. Your input and participation is critical in advancing the science. So a few meeting additional notes. So there will be 4 thematic sessions: etiology, clinician's perspective, methodology and tools, and intervention research. There will be 2 flash talk sessions and 1 breakout session later on this afternoon. So I would like to acknowledge all the efforts of the planning committee and their trans NIH, and without your efforts, we would not be able to make this workshop happen. A few housekeeping items: maintain your time limits, mute when not speaking, enter your questions in the Q&A box, and for technical issues, contact Mark Gifford. This leads me to introducing our Deputy Director, Dr. Monica Webb-Hooper, who's a leader in minority health and cancer health disparities research. Dr. Webb-Hooper joined NIMHD as the Institute celebrated its 10th anniversary. Her work spans multiple populations experiencing health disparities, including African Americans, Hispanics, and Latinos, persons of less socioeconomic privilege, and persons living with HIV and AIDS. She came to NIH from the School of Medicine at Case Western University, where she was a professor of oncology, family medicine, and community health, and the psychosocial sciences. She also served as an associate director for the Cancer Disparities Research and director of the Office of Cancer Research at the NCI-designated Case Comprehensive Cancer Center. As a licensed clinical health psychologist, she led an active research lab focused on chronic disease prevention, health behavior change, tobacco use, weight management and obesity, stress processes, biobehavioral interventions, and social determinants of health. Welcome, Dr. Webb-Hooper.
Thank you very much, Carlos. I really appreciate the introduction. And I have to say that I'm just really delighted to be here and be able to participate in this workshop. I want to add my welcome and my thanks for everyone for joining us. I also want to, of course, acknowledge the hard work of the planning committee for organizing this workshop. And, as a clinical health psychologist, this topic is one that I think it's wonderful to see an increased focus on, and progress in this space is really needed. So I'll say a bit about NIMHD to start. Our mission is to work across NIH, as well as the Department of Health and Human Services more generally, to advance the science of minority health and health disparities, move us closer to meaningful progress. We are disease agnostic, given the cross-cutting nature of these issues. So we do our work by supporting cutting-edge science in health behaviors, in specific diseases and chronic conditions, and social determinants of health. We also support the training and development of a diverse science workforce, and we also focus on communicating findings, translating findings, and we have a strong emphasis on partnership and collaboration. These are the groups that NIH has designated as U.S. populations that experience health disparities. So the groups encompass about 70% or close to of the U.S. population. They include all racial, ethnic, minoritized groups, socioeconomically disadvantaged populations, underserved rural populations, sexual and gender minoritized groups, as well as people with disabilities. And we know that, for example, racial and ethnic minoritized groups and persons with less privileged socioeconomic status experience a disproportionate burden among many conditions, including those you see listed here, as well as others. Now, the patterns do show some differences across groups, but the main issue is that these disparities are longstanding, except for COVID-19 perhaps, and they're well known, and there has not been enough measurable progress, even though many of the factors that increase the risk of severe outcomes are preventable or addressable. Now, I hear this phrase more and more, health equity research, but I don't think of equity as a type of research. It's a principle that we apply continuously. It's a lens that we apply in all of our work, even when it's not focused on health disparities. Equity is synonymous with fairness, with opportunity, quality, and social justice. It's not an outcome that we reach and then we're done. Health equity is an assurance. It means that we go out of our way to ensure that everyone has these opportunities for optimizing their health. True health equity work is not easy. It involves changes in laws, policies, processes, norms, resource allocation, and power structure that affect access to healthcare and adverse social determinants of health. So when someone says that they are conducting health equity research, these are the domains that I would expect to see. Now, in thinking about this workshop and thinking more about how interpersonal bias as an area of scientific inquiry fits into the NIMHD strategic plan, wanted to just note that our current strategic plan is on our website. We're in the current cycle, which ends at the end of 2025, and it's a helpful reference for understanding NIMHD research priorities. It describes goals for advancing minority health and health disparities research and promoting health equity in three major categories: scientific research, research sustaining activities, which are really about strengthening the national capacity to address these issues, and then outreach, collaboration, and dissemination. So, there are many goals within the strategic plan. These are just a few that directly seem relevant to the concept of this workshop and on interpersonal biases and health disparities. So looking at goal 1, which is really the one focused on racial and ethnic the health of racial, ethnic, minoritized groups, broad areas that would help move the field forward that I think about work on, the impact of interpersonal biases. Research has shown, and we'll hear more about the impact of interpersonal biases, including implicit and explicit prejudices, and how they contribute to differential treatment potentially and outcomes for racial and ethnic minoritized people in healthcare settings. And the patterns do differ by race and ethnicity. And of course, the trouble is that these biases can lead to misdiagnoses, inadequate treatment plans, and reduced access to necessary healthcare services, perpetuating health disparities. So, and also secondly here, improving health outcomes. This is always our goal. So by addressing and mitigating interpersonal biases, healthcare clinicians can offer more equitable and effective care, improving health outcomes for racial and ethnic minoritized groups. And always focus for us is also on developing training programs as well as interventions that effectively reduce biases, or I would probably say help healthcare clinicians or providers manage the biases that they have. And then the second goal in our plan that I think is really relevant here is on advancing overall scientific understanding of the causes of health disparities. So at least two overarching things to think about here: root causes of disparities. Interpersonal biases are a significant but often overlooked root cause potentially of health disparities. And, they impact patient-clinician interactions, they impact healthcare delivery. I also think that understanding how these biases influence health outcomes is helpful. We need to identify the mechanisms through which disparities are perpetuated. And then it's really important that this work is comprehensive, it's multidisciplinary. It approaches this through the exploration of psychological, social, and structural dimensions of biases. And also this would include studying how these biases intersect with other factors like socioeconomic status, like geography, and systemic inequity. Third goal I wanted to point to is on interventions, right? So developing interventions that specifically target the reduction of interpersonal biases in healthcare settings is crucial. Effective interventions, they might include implicit bias training. We know the data are mixed here. Cultural competency education, policies that promote diversity and inclusion in healthcare teams. It's always important as part of our scientific methods that we evaluate the impact, right? Rigorous testing, evaluation of any interventions that we develop are necessary to determine their effectiveness in actually reducing a gap, closing a health disparity. Longitudinal studies are important because they can assess how the impact of bias reduction may be sustained over time, how that impacts programming on healthcare and outcomes for minoritized and other underserved populations. A fourth goal in our strategic plan is around the scientific methods, the metrics, measurement tools that would support this effort. We certainly need to develop more robust tools to measure the presence and the impact of interpersonal biases in healthcare, essential. And the tools should really be sensitive to detecting those really subtle biases and their effects on patient care and outcomes. And NIMHD strongly encourages the use of standardized metrics for assessing bias and its impact as we want to facilitate comparative research and how we evaluate our interventions. Also important for helping us identify the best or the promising practices that exist and scaling up successful interventions across diverse healthcare and other settings. And then the last goal I wanted to point to as it relates to this topic is on, the workforce and on developing capacity. We want to have a community of practice of diverse researchers, advocates, really crucial for addressing interpersonal biases in health disparities research. We want participation from individuals with diverse perspectives and experiences, as their views and their experiences are really important to inform our research priorities and our methodology. And then a final note about training, it also fits here. Training and mentorship opportunities that include researchers from minoritized and underserved backgrounds can really enhance capacity to continue in our area of inquiry in this domain. And then, of course, fostering authentic collaborations between researchers, healthcare clinicians, communities can lead us to the more comprehensive and impactful research efforts that we would like to see. Now, we know the research and the research framework, the NIMHD research framework, and we know that much of the research in science and in medicine has kind of focused on individual level biological mechanisms or individual level behavior as how we understand and explain the often poor health among minoritized groups and for disparities. But as you can see, if you focus singularly on one area, biology or individual behavior, or any other singular effort, it misses the great complexity of understanding and addressing health disparities because we are not fully spanning those other domains of influence: physical built environment, sociocultural environment, healthcare system. And it also means that we're not looking upstream at community, societal levels. So this workshop focus on interpersonal level is really important. And I also think it's important to note that these boxes and this framework are really here to make the point, but not to suggest that these constructs are mutually exclusive or can be, only investigated in an orthogonal fashion. The model also doesn't specify bias or sort of the general preference for or against a person or social group, a thing or idea, but I wanted to note that it does center racism and discrimination as sort of notable factors, extreme forms of bias that affect minority health and health disparities. And we see this across all of our levels of influence within our sociocultural environment. Also wanted to make sure that you are anticipating a very important report that will soon be released. It's a project commissioned by NIMHD in partnership with other NIH institutes and centers, as well as AHRQ. And in the next few months, this report will be released. It is an update of the landmark 2003 then Institute of Medicine report on unequal treatment in medicine. And in that 2003 report, the Institute of Medicine concluded that unrecognized bias against members of a social group, such as racial or ethnic minoritized people, may affect communication or the care offered to those individuals. Now, I remember this time when this report was released, and the finding really had a major impact on the field. And some people were not pleased with this notion of bias against minoritized patients, especially clinicians delivering care, right? But the data were there, and they kind of say what they say. So this is an overview of the goals of this updated and the new report that we can expect. There were workshop proceedings published recently within the past month or two, and we shall see, right, what the data over the past 20 years has to say. I want to say something about measurement. Carlos mentioned this, and I've mentioned it, and I'm sure we're going to hear a lot about this topic. And, we would always say that it's hard to improve what isn't measured. This is something that has not been measured, but it's also hard to improve if we're not all measuring the same thing when we do focus on this space. So I want to encourage the use of standardized measures. We have a social determinants of health special collection that NIMHD supported in the Phoenix Toolkit. We do encourage the use of our core collection for all human participant studies. And then there's also specialty collections, one of 23 individual level social determinants of health measures, and another with 14 structural or community sort of data sources. It's on the website, you could easily find it, but I did want to note that several of the measures, particularly within the individual specialty collection, are relevant to how we assess self-reported experiences related to interpersonal biases, such as disparate healthcare quality and discrimination in healthcare. I've highlighted those in red. And then the structural collection, just to note, these are measurement and data resources, often publicly available data sources at the structural or community level that are used, using data, for example, from the American Community Survey. So really important resource that you should know about. There are also a number of funding opportunities at NIMHD that are active and that are very relevant to the discussions that will happen over the next 2 days. So I'll point to just a few of them. There is an active program announcement on patient-clinician relationships, which specifically is looking for as areas of interest, including but not limited to kind of the multi-directional roles of racism, discrimination, as well as implicit and explicit bias, and strategies that would address patient and clinician biases. There's another one here that's active until the fall of next year that's focused on structural level racism and discrimination on minority health and health disparities. These applications are expected to provide a conceptual model that identifies hypothesized pathways that link structural racism and discrimination directly to health outcomes. And it's expected that this one goes above the individual self-reported perceptions and experiences to look at, the organizational, community, or societal levels. And then we also have an active opportunity on observational and intervention-based research to identify and characterize pathways and mechanisms through which health and healthcare disparities occur and affect social, sexual, and gender minoritized groups as well. So just take a look at our website to keep track. And we were really just delighted that Carlos led this initiative, that this concept has been approved by our NIMHD's advisory council, and it will look at this topic of interdisciplinary, multi-level approaches to understand the impact of interpersonal biases on health outcomes and disparities. So this is also on our website, on our council webpage, so you can look to see exactly what NIMHD program staff are thinking about for this initiative. And I'm sure that this meeting will help inform the ultimate funding opportunity that we hope develops from this concept and from the workshop. So I think, there are a lot of questions to be asked. Carlos mentioned a few that we should think about. I'll also offer a few. We have gaps, right, between reasonable inferences about bias and then what's known. So I'm excited that we're having this workshop, that you all are here. Over the next couple of days, I hope that we have state of the science updates on interpersonal bias research and health disparities. These are just a few questions that I'll be listening for answers to based on the extent data, looking at, the extent to which interpersonal biases exist, how they affect different social groups. Are they more likely in some domains compared to others? Do they affect, and how do they affect clinical outcomes? And if intervention is possible, what strategies are most likely to be successful? And I'll end here. Unite, NIH Unite initiative is hosting a 2-day workshop next month, in exactly almost a month, and on campus at NIH. It's also virtual, and it's on interdisciplinary approaches to understanding and addressing structural racism in health. Would like you to attend. You can go to the website. The Unite website is Ending Structural Racism, or just NIH Unite. There's an events tab that has the registration information and sort of the draft agenda as it's coming together. So we'd like to see you there. And I encourage you to follow NIMHD on all of our social channels, keep track of what we're doing. And thank you all for being here and for allowing me to help open the meeting.
Thank you very much, Dr. Webb Hooper, for the insightful and perspective, the NIMHD perspective. So without further ado, let me go ahead and share my screen. Okay, so next, it is my distinct honor to introduce our keynote speaker for this workshop, Dr. Sandro Galea. Dr. Galea is a renowned physician, epidemiologist, and author who currently serves as the Dean and Robert A. Knox Professor at the Boston University School of Public Health. Dr. Galea's illustrious career includes academic and leadership roles at Columbia University, the University of Michigan, and the New York Academy of Medicine. He has made significant contributions to the field through his extensive publications in peer-reviewed literature and his regular contributions to various public media outlets, focusing on the social causes of health, mental health, and the impacts of trauma. Recognized as one of the most widely cited scholars in the social sciences, Dr. Galea's influence extends beyond academia. He currently chairs the Boston Public Health Commission Board of Health and has previously chaired the Board of Association of Schools and Programs of Public Health. Additionally, he is a past president of both the Society of Epidemiological Research and the Interdisciplinary Association for Population Health Science. An elected member of the National Academy of Medicine, Dr. Galea has been honored with several Lifetime Achievement Awards, underscoring his profound impact on public health. His academic credentials include a medical degree from the University of Toronto, graduate degrees from Harvard University and Columbia University, and an honorary doctorate from the University of Glasgow. Please join me in welcoming Dr. Sandro Galea. Dr. Sandro Galea, the floor is yours.
Thank you, Dr. Garrido. Thank you for a very, very kind introduction. Thank you for inviting me. I'd like to thank Mark Gifford for all your organization, and to Dr. Webb Hooper for outstanding introduction. I'm going to share my screen. So I was asked to make some framing remarks, and perhaps I'm going to sort of go back a step from where Dr. Webb Hooper's presentation was, to talk about population health science more broadly. And looking at the rest of the agenda, which looks really interesting, I can see why the organizers asked me to do this, to really take a step back and think a little bit more globally, think about population health as it frames the biases. And a lot of my remarks reflect a paper that I had written specifically for epidemiology, which is Dr. Garrido mentioned is my own discipline, which was called Reckoning with Our Biases in Epidemiology, but here broadening a little bit of population health science. I'm going to just talk for about 15, 18 minutes. So let me plunge right in. I thought I would start with two cautionary tales that illustrate the enormous impact that bias has on how we think and on how population health. I thought I would go back first to the 19th century. This is perhaps one of the most important discoveries ever in public health, which is the importance of hand washing. Hand washing was the earliest empiric data on hand washing came from Ignaz Semmelweis, the gentleman on the top left, who showed that in his observations on the wards, that these you can see over time. The blue bar, the blue line, which is the lowest line, is the percent of women who had puerperal fever, essentially postpartum fever, after delivering babies. And the pink line is also women. The difference was that the top line were women delivered by doctors, and the bottom line were women who were delivered by nurses and midwives. And Ignaz Semmelweis, Dr. Semmelweis, observed that doctors were doing autopsies down the hall and before they go on to deliver babies. And he suggested that one of the reasons why there were more women who were developing postpartum fever and dying from it is because doctors' hands were dirty. Hence, he suggested hand washing. You might think that such a radical observation, with such a dramatic statistical backing, would be well received at the time, but leading obstetricians of the day, including the Charles Meigs, who was actually had many other dubious challenges in his field, has this quote, which is, "A gentleman's hands are clean," which was used to dismiss the work of Ignaz Semmelweis. Ignaz Semmelweis was eventually drummed out of the hospital where he was working in, and he died quite marginalized and quite poor. And of course, he was of course right. So this is, to me, it's such a simple, stark, terrible illustration of biases. This notion here, this is a clearly sexist, misogynist bias that with a very particular lens on the world, which resulted in more people continuing to die unnecessarily when the science was right there in front of us. That's one illustration. I'll fast forward then to some of the biases which I'm going to talk about in a second, which affected our more present moment in a time of COVID, which was public health's finest hour in many ways, bringing about vaccines that have literally saved millions and millions of lives around the world, vaccines that were developed very quickly. But despite the fact that COVID was public health's finest our trust in a lot of the institutions of public health has gone down dramatically. This looks at people who identify in this country as Republicans or non-Republicans, and what you see is among people who identify as Republicans in particular, you have a drop in trust in CDC and NIH and medical experts and in international health agencies, and also the case for some of these people who do not identify as Republicans. And when you look at other data on support for public health measures by trust in science, you see the bars from left to right go from not trusting science all the way to a lot of trust in science, and you see enormous difference in whether or not people are willing to support some of the core things like wearing masking, social distancing, contact tracing is important by trust in science. So somehow something about how we approached the COVID moment, despite our successes in it, resulted in this lack of trust. So I'm going to come back to in a second. So I just want to start with those two cautionary tales. Before I actually move into what biases specifically, I did want to just talk a little bit about our responsibilities, and what why it is so important that we pay attention to our biases. And Dr. Webb-Huber anticipates some of this when she talked about health disparities. But very briefly, in this country, our health has lagged behind other countries for many years. It lagged behind in terms of COVID, lagged behind even more than COVID, and has not recovered as quickly as other countries in context of COVID. Here, this chart shows observed life expectancy during COVID, which is on the left. You see the US at the bottom, and you see our drop in life expectancy. On the right, you have a counterfactual, assuming no COVID deaths, showing that other countries will have slowed down, but the US slowed down even more and has dropped even more. So there is a significant burden of poor health in this country that I think all of us in population health science, which is a foundation of the practice of public health, have a responsibility to do everything we can to try to illuminate why it is that we allow that to happen. And as Dr. Webb-Huber well pointed out, a lot of this poor health is experienced unevenly. This is one of the slides that I find is most compelling, showing that while there was a decline in life expectancy overall in the context of COVID, there was an extraordinary decline of 6 years among particular groups, particularly Native American groups in a time of COVID. So we have a tremendous responsibility to meet, to live up to, as we try to figure out how we can actually create better health. And we have a responsibility to think through what is it about biases that influence how we do what we do, when even in a moment of triumph, like in the context of our contribution, in the context of COVID, where we end up with loss of trust, which surely must have something to do with things that we are doing. So what drives our biases? And, I actually, when I was first approached to speak at this, I was honored to be asked, but I had to pause for a moment to reflect on it, because I think it's actually awkward. It's awkward and uncomfortable to think about what it is that causes our biases. It's awkward for me to even try to structure my talks. It's awkward for me to write about it. Awkward for me to think about my own biases, which I realize I have every day. I thought this quote from Judith Butler captures well, I think, why it's important to talk about things that matter. When she says the matters most in need of public discussion, the ones that most urgently need to be discussed are those that are difficult to discuss within the frameworks now available to us. And I think their comment here that matters most in need of discussion, ones most urgently to discuss, are difficult to discuss within frameworks available to us, is a very astute comment. And I think biases are like that. Biases are like one of these, Dr. Butler here was referring to something else, but I think their comment is correct, that there are some things that are really important to discuss that actually we don't have frameworks that are easily accessible to us to discuss. That's why I want to commend NIH and NIMHD for pulling together this kind of workshop, because I think it pushes us forward to develop frameworks to think about things like biases. So as I was thinking about organizing my thoughts, I thought I would talk a little bit of biases structured in three ways: biases that emerge from who we are, how we think, and how we act. But so what is it about who we are that makes for biases that influence population health sciences? What is it about how we think that leads us to biases? And what is it about how we act that imposes our biases? The who we are, I'll start with, is perhaps the easiest one of these, because we think about this quite a bit, and we think about it particularly in the diversity agenda. We know from data, this is data from epidemiology, which is my discipline, showing a disproportionate representation of persons with a background as white or Asian in epidemiology, and underrepresentation of underrepresented groups like Latino, Latinx, Black, African American, that have long been underrepresented in epidemiology. So this is part of who we are. This is also true for other fields in population health sciences, other fields in public health. But there are other aspects of who we are that we don't often think about as much. For example, one of those aspects is our political affiliation, our political leanings in population health science and public health. This looks at academics, this looks at professors, associate professors, assistant professors. The three bars represent the different levels of professors, and this looks at to the left of the political spectrum, to the right of the political spectrum. And what you see is only about 10% of professors in institutions of higher learning self-describe as having rightward leaning in politics. And there are many reasons for this. There's many reasons why we in the academic world may lean more on the left of the political spectrum. But of course, it also means it presents a particular way of looking at the world, a particular bias. Just to show an example, in COVID times, something that about who we are that really affected, I think, how we intersected in COVID. This is from a poll that was conducted in 2020, and this looks at people who said the following factors improved for them in 2020. And the factors are, if you look at the top of this, mental health, personal finances, job security, take-home pay, physical health, personal life, work-life balance. Under the line means you did worse. And you see everybody did worse on all these dimensions, with the exception of two spikes, which is one set of spikes is where people had a postgraduate degree, and another set of spikes, which is coincident, which is people making more than $100,000 a year, making six-figure incomes. Where actually a lot of those things improved in the context of 2020, where people stayed at home more, they had less work, they had more time to spend with their family, and they actually ultimately felt safe. So that creates who we are. And by we, in this context, I'm talking about those of us in the room, if we are different, substantially different than the public that we are committed to serving, it creates a bias, a lens that we look at through things differently. One other example is, for example, looking at our decision makers in this country in terms of who we are. I'm just now broadening from epidemiologists to all of us in population health science to Congress. One of the areas on which Congress, who Congress is, and I'm using Congress as an exemplar of decision making, is most different than the rest of the country is represented here by this graph. What you see is only 4% of people, I didn't label it on purpose. Normally I might ask you to guess what it is. Only 4% of members of Congress do not have a four-year college degree, while in the US as a whole, 65% of the country does not have a four-year college degree, which again presents a difference in terms of who we are, and by the we here as decision makers in the country, than the public that we're trying to serve. And by we being different than the rest of the population we're trying to serve, whether we as epidemiologists, scientists, population health scientists, academics, people in the broader academic, media, political complex, by being systematically different than the populations we're trying to serve, it puts us in a different mindset that creates biases that are hard to overcome. So axis A is who we are. Axis B is how we think. There's many different ways in which we can think about how we think, and Dr. Webb-Hooper talked a little bit about some of the social psychological ways of thinking about biases. I actually want to keep this in my comments at the level of population health science, and I'm going to use a couple of examples in the context of COVID, because I think they illustrated really starkly how we think is a bias that emerges from who we are. In the context of COVID, there was a lot of surfacing of the salience of those of us in public health, particularly epidemiologists, which on the right, you see something from New York Times, what epidemiologists are doing for Thanksgiving. There were other things what epidemiologists are doing for Christmas, etc. Really, I think giving us a robust sense of the importance of epidemiologists and public health professionals, all of which was correct, but of course, all of which might make us make mistakes in terms of how we think. On the left is a quote from a paper which I quite like, which is, with a lot at stake, it's wise to be humbled when faced with fundamental limitations. And epidemiology, speaking about my discipline, is sort of one of the core quantitative disciplines of population health sciences, has fundamental limitations, and that humility is hard to maintain when how we think is being influenced by people asking us what we're doing for Thanksgiving. That led to things like follow the science, these notions that science had all the answers in the context of a pandemic. We knew well, this is something for which I had written with a colleague, other people have also written about this, that science has its own limitations in the context of guiding public policy. But we didn't really allow those limitations to inform very much how we thought during COVID, which resulted in biases which might have well affected what I showed you earlier when I led into it. I'll just show you one concrete example. When COVID hit as a respiratory disease that was transmitted person to person, and one of the very fastest things that happened is became an emergency declaration, but also we all behaved in a way that anybody who could work remotely went to work remotely, which at some level seemed obvious, at some level seemed like the rational thing to do. But of course, we knew before COVID who could work remotely. This is data from Bureau of Labor Statistics in 2019. And what you see here is that among people who work on the far right, 25% of people in the top 25% of income, 62% of people in top 25% of income could work remotely. In the other 3/4 of income, which means 75% of the population who worked, only a minority could work remotely. And in fact, when the emergency declaration was announced in March of 2020, what you see here is two lines. The gray line is the wealthiest 20% of the population. The red line is the bottom 20% of the population, which is once COVID hit and the emergency declaration was declared, who stayed home? Well, it was people who actually had more income, who were in the highest echelons of income, and others who were in the lower, who were making less money, were not able to stay home. Fewer of them stay home. And in fact, that translated in the first year of COVID into who died in COVID. People who died in COVID-19 by occupation, were bus drivers, construction workers, cooks, laborers, material movers, manufacturing workers. Those are the people who died in COVID. And those people are disproportionately represented by people of color. This on the left looks at workers at risk, saying more or less the same thing as the previous one. But what you see is Black workers are more likely to be in frontline jobs than non-Black workers, more likely to be in grocery stores, public transit workers, warehouse workers, etc., which of course was part of the early explanation for some of the racial differences. A lot of these things changed over time. So the notion that an idea is self-evident, like the fact that we should all stay at home if there is a novel respiratory infection, if we can, it's a really difficult notion. And I think that may seem very simple. It may seem like a very linear way to think, but it's actually a much more complicated question. Because if we are, as Dr. Webb-Hooper said in their introduction, if we are to center health equity, saying that everybody who can stay home should stay home is effective to saying that we are willing to expose people to differential risk based on their occupation, based on their income, and coincident with that, based on their racial ethnic identity. So as number two is how we think can embed biases that are very hard to see. Number one is who we are. Number two is how we think. And number three is how we act. And sticking a little bit more on my COVID examples, which I'm choosing throughout here, there's been a lot written, a lot of discussed about how we acted during COVID, a lot about our communication. And, a lot of our communication, we acted in a way that I would argue diminished trust because of our communicating certainty that turned out to be wrong. On the left, some from CNN, the world's still arguing about masking. On the right, a scientific paper that actually shows that communicating uncertainty doesn't really affect trust. Knowing this should allow academic science communicators to be more transparent about limits of human knowledge, which of course is not what happened in COVID. So how we acted emerged from who we were, emerged from us thinking in a particular way, and then we acted with a sense of certitude that resulted in a number of things, including, for example, things like the case for zero COVID. It resulted, for example, in extraordinary efforts to contain COVID in China, which was, of course, then conflated with a lot of political messaging and with a lot of advocacy groups pushing for this one very particular way of dealing with COVID, suggesting that any other approach to deal with COVID was not meeting our responsibilities as public health professionals. But of course, that argument, acting that way, forgets that everything we do in population health science leading to public health is always a balance of trade-offs. In fact, we balance trade-offs all the time whenever we set things like speed limits, because we know that higher speed limits are going to result in more people who are dying. And we know that it's a large number of deaths that we could avoid if we lower speed limits. And society is constantly balancing risks and trade-offs. And when we act with this kind of certitude emerging from how we think, emerging from who we are, we lead ourselves down a particular path, which then results in some of the things that I showed earlier about the lack of trust, despite the fact of how much good public health did in the time of COVID. As I wrap up, I did want to point out that the consequences of our biases, the consequences of us being different than the population we serve, of thinking different than population reserve, acting in a particular way that the population reserve does not trust, is actually quite dramatic. I talked about trust, which I'll come back to in a second, but also there are actually our poor achievement in health has enormous political consequences. There are data now both from this country as well as from other countries that show that poor health is associated with the greater likelihood of election of populist leaders. This was in the US, showing that counties who are doing worse on health, which is on the left of this graph, were much more likely to elect Donald Trump as president of the United States. And also showing, this is from European countries, showing the exact same thing, that places which rate their health as being bad or who are more hampered by disability are more likely to elect populist candidates. Populist candidates typically say the system's not working. The system's not working for you. And when your health is not doing well, it's reasonable to feel the system's not working for you, which then results in political transformations that often end up not having the best interests of the people who initially wanted the change to begin with. So our biases and our letting health fall behind has enormous implications, not just for trust in our science, not just for how we do our science, not just for how we interact with one another, but for a larger political landscape. I think some of this leads us to potentially think carefully about needing to think differently about health, leads us to think about what is it that has animated people so much in a context of time when we saw health achieve such prominence and seeing these biases emerge, and leads us to ask important questions about what does it mean when the percent of people who are saying that science is mostly a positive effect on society is going down dramatically among on the right, people who self-identify as Republican, but also people who self-identify as Democrat who are also Black or Hispanic, also going down in those groups. So I will stop there. I just wanted to offer some early thoughts, early provocations about how we think about biases, how we think about bias at the population level, how we might want to frame how who we are, how we think and how we act shapes biases and their influence on populations. I don't really have particular prescriptions, but I do think that workshops like this have a really important role. I show here a sort of a 10-step plan that we have long articulated and tried to follow in the school I have the privilege of leading, about how to create a more equitable, inclusive, diverse environment. And the reason I show this is not actually to dwell on it, but simply to show there's no one thing that I think is a solution, but I think there's actually many, many things that have to happen all at the same time. And then to just simply say that, thinking about biases, labeling biases in who we are, how we think, and how we act is, I said at the beginning, it's difficult, it's uncomfortable. And I like this quote from Professor Colgrove, which I use sometimes, which is initially this seems silly, then it seems controversial, then it seems progressive, then it seems obvious. And I think, I'm hoping that it's through changes in our discourse like this, is through workshops like this, through the work that Dr. Garrido, Dr. Webb Hooper, everybody at NIMHD and everybody on this call is doing, it will shift to a place where it seems obvious that there are biases in who we are, how we think, and how we act, so that we may slowly work towards disentangling those biases towards the end of generating better health. This is just a book that I published recently, and the right is a blog in which I do a lot of writing, some of which informs this. But I will stop sharing. It is really an honor to be here with you. Thank you for inviting me. I look forward to comments and questions.
Thank you so much, Dr. Galea, for such a thought-provoking and compelling presentation. For certain, your insights into the complexities of public health and interpersonal biases have pretty much provided a very valuable perspective, and as we consider how to take this work forward. So we deeply appreciate your contributions to this important discussion. So I will go ahead and take the honor to ask you the first question. So given your profound impact on leadership in public health, so what key actions do you believe from public health agencies that they should undertake to reestablish trust in public health and in the sciences among the general public? And how can these actions help bridge the gap between scientific communities and the public in order to ensure more informed, trustful society?
Yeah, thank you for your question. My long answer is I don't know in full. My shorter answer is I actually think talking about these things is a critical first step. I actually think the fact that NIMHD is doing this workshop is an important first step. I think the fact that we are allowing these ideas to surface is a critical first step. I think being able to having civil, open agreement or disagreement about these ideas amongst ourselves within the population health science community, within the public health community, and saying, Dr. Garrido, you may say, Sandra, I don't agree with points 1 and 2 you made. And that's okay, and I think that's okay. But I think surfacing these ideas pushes us to think about it. When I address the point about the National Emergency Declaration about staying home from work, I often get people challenge me on that and say, well, what else do you want us to do? And to which my answer is, I'm not exactly sure. But I certainly wanted us to be aware of what we're doing when we're doing that. And I would hope that we'll be much more sophisticated about next time something like that happens. So I do think step A is the conversation. Step A is surfacing the issues. Step A then is learning from that and then having the humility to figure out what we can do better.
Excellent point. Particularly, we need to know that there's a problem in order to be able to strive to fix that problem. Problem being distrust for public health. So thank you for that answer. I have a question from Dr. Rina Das. Can you suggest areas of research that will improve our understanding of bias, how that can impact health outcomes, and any thoughts on resilience to buffer the impacts of biases?
Yeah, I mean, I do think that I mentioned when I was approached to speak at this workshop, I was hesitant. A, because I think it's a difficult topic, but B, I thought it's an unusual topic for a workshop. So I was actually quite happy to see that, and I think that means that there is plenty of room for scholarship in this area. I think there's room at the population level, all the way down to the individual and psychological level. So I think it combines sort of what Dr. Webb Hooper said and what I said. I think there's room at the population level. When I talk about who we are, well, how does one actually make sure that who we are represents better who we serve? And what does that mean? On what axes do we represent? How do we then think? How do we organize how we think so that it is aware of who we are and the difference of who we are? And how do we act differently despite how we think and despite who we are? I think those are all areas of research that are important.
Excellent. Thank you so much.
I have a direct question to me, which I'll read out loud from Yvette Lopez.
Asking, yes, please do.
Asking, how do I think addressing bias changes according to geographic and demographic specifics? I think it's an excellent question, actually. And I don't think addressing bias changes. What I do think changes is an awareness of the populations we're trying to serve and how who we are and how we think and how we act intersects with those populations and often intersects differently depending on who those populations are. So I do think that we saw a lot of that playing out in the country in the time of COVID in many respects. It's not as one country, but as 50 countries with really tremendous heterogeneity between them. So I think we need to be conscious, constantly conscious of how who we are is or is not representing the people we're trying to serve, how we're structuring our thoughts may or may not reflect the people we're trying to serve. I find the mismatch, for example, between Congress's 4% to 65% of the population truly dramatic. Now, there's plenty of reasons why you want members of Congress to have more, let's say, formal education than people in general population. But that's quite an extraordinary difference, right? It is akin to the challenge that we have, for example, when nobody in Congress has any children who are engaged in the military, well, Congress is entrusted with starting or continuing wars. One sees the world very differently when your loved ones are in harm's way. One sees the world very differently when you or your loved ones are in harm's way or not in harm's way, depending on a particular emergency declaration. I think that's part of how who we are may or may not represent the populations who we serve. It's part of how who we are informs how we think and how that then informs how we act.
Excellent points. Does anybody else have a question? Well, Dr. Galea, like I indicated, thank you so much for such a thought-provoking and compelling presentation. Thank you for agreeing to present as a keynote speaker. It is certainly a treat and an honor to be able to invite you here and address the public on this very special topic and ways to be able to move the science forward. So sincerely, thank you so much. And yeah.
Thank you to you, Dr. Cooper, and thank you to everybody here. It's a privilege to be here.
Thank you. So next up, we have the first thematic session titled Etiology and Mechanisms that link link interpersonal biases and health outcomes. That will be moderated by Dr. Amanda Acevedo. Dr. Acevedo, the floor is yours.
Hi, can you hear me okay?
Yes.
Okay, great. Thank you so much, Carlos. As he said, my name is Amanda Acevedo. I am a program officer in the Division of Cancer Control and Population Sciences at the National Cancer Institute. And I'll be moderating the session titled Etiology and Mechanisms to Elucidate the Link Between Interpersonal Biases and Health. Our first speaker of this session is Dr. Julian F. Thayer, who is a distinguished professor of psychological science at the University of California, Irvine, and the Ohio Eminent Scholar Professor in Health Psychology Emeritus and Academy Professor at the Ohio State University, who will be presenting on physiological responses to unfair treatment. Dr. Thayer's area of specialization is psychophysiological aspects of self-regulation, particularly parasympathetic influences on physical and mental health, including hypertension, anxiety, and depression. Please welcome Dr. Thayer.
Thank you, Amanda. Welcome, everyone. I'm going to start to share my screen here. Let's see if I can get this to work. Can everyone see my slides?
Yes, we can.
Perfect. So I'd like to start with a quote attributed to James Baldwin. And this arose in the context of the national reckoning associated with the murder of George Floyd. And it's often quoted in the press as to be Black and conscious in America is to be in a constant state of rage. But that's not exactly what Baldwin said. This is what Baldwin said in 1961. To be a Negro in this country and to be relatively conscious is to be in a rage almost all the time. So that and the second sentence is the most important. So the first problem is how to control that rage so that it won't destroy you. In this context, we've been doing a fair bit of work, and one model that we have proposed is the generalized unsafety theory of stress model. And there are several guts principles. The stress response is the default response. From an evolutionary perspective, this is an adaptive response. The physiological state is co-determined by perception of safety. Perceived safety is the outcome of the brain's prediction of survival chances. The stress response is largely unconscious. No stressors are needed for prolonged stress responses. And perceptive cognition is a part of generalized unsafety. And safety signals for humans are primarily social and learned. So let's dig into this a little bit further. So the default response to unsafety is the fight or flight response. Again, from an evolutionary perspective, this was adaptive. I don't have time to get into all the details, but with respect to the topic of this talk, this will show itself at elevated baseline levels, not necessarily in exaggerated reactivity. Third, safety has to be explicitly recognized, either consciously or most likely unconsciously, to turn off the stress response. And importantly, number 4, this shifts stress theory from a focus on threat to a focus on safety. And just by way of some examples, so this paper from Main and colleagues looked at perceptions of safety and blood pressure in the MESA study. And what they found was that a standard deviation increase in individual level perceived safety was associated, with a 1.54 millimeter of mercury reduction in systolic blood pressure overall, and a 1.4 millimeter mercury reduction in diastolic among women only. Increased neighborhood level safety was not associated with blood pressure change. And these results suggest that individual perception of neighborhood safety may be particularly salient for systolic blood pressure reduction relative to objective neighborhood exposures. And this is just a figure showing these reductions. And what you can see is that this reduction of nearly 3 millimeters of mercury in women for each standard deviation increase in perceived safety is quite biologically meaningful. A second study looked at did sort of an environment-wide association study. This is sort of a psychological version of a genome-wide association study. And what they found in nearly 12,000 individuals, that they identified 21 environmental factors that were associated with well-being, and noted that socioeconomic status and safety were the most important. So especially neighborhood safety could be informative for policymakers and guide policy to improve well-being. So this just sets the broader stage of how safety is a key factor. What I want to get into now is a specific physiological pattern that we have identified that we call the cardiovascular conundrum. And this is a pattern of physiology that we believe is elicited in response to unfair treatment, and it's associated with high heart rate variability, which should be protective, and high total peripheral resistance, which is clearly deleterious because it's associated with elevated blood pressures. So we have identified this in a number of ways, and we did several meta-analyses, and in some ways, much to our what the field's surprise, higher heart rate variability was found in the African Americans, nearly a full standard deviation higher heart rate variability. Given their increased health risk, one would have expected lower heart rate variability. My dear friend, Dr. Norman Anderson, passed away, unfortunately, recently, in a prescient paper in 1989, suggested that Blacks may show a propensity towards blood pressure reactivity mediated by peripheral vasoconstriction. This alpha-adrenergic hyperreactivity, as indexed by peripheral vasoconstriction, may prove to be an important contributor to elevated blood pressure in Blacks. So in a meta-analysis we did with Norman, we found that Blacks indeed had about a third of a standard deviation higher total peripheral resistance compared to whites. Now, this cardiovascular conundrum pattern, and here's just the forest plot, is also evident. This is data from MESA, where we looked at heart rate variability as measured by the RMSSD measure and systolic blood pressure. And you can see this graded relationship such that African Americans have both higher heart rate variability and higher systolic blood pressure. Interestingly, there are some also intersectionality issues such that these effects are larger in women compared to men in the minoritized groups. And this is consistent with what was found in the first study I talked about. Now, in a study of about 12,000 individuals, we looked at how reports of discrimination might mediate this effect. This is a study done in Brazil, where there are 3 phenotypically defined ethnic categories, the English translations of which would be black, brown, and white. And what we found was that the blacks reported greater discrimination than the browns, than the whites. Blacks also reported a higher rate of hypertension, and they also had higher rates of heart rate variability. When we statistically controlled for discrimination, the ethnic difference in heart rate variability was attenuated. And what we said was that the higher HRV in Black individuals may reflect a heightened yet forced capacity to regulate emotions associated with day-to-day stressors and discrimination against Black and brown individuals. Some previous studies support this possibility. Firstly, Blacks may be conditioned from an early age to inhibit their expression of anger in effort to reduce or avoid aggression, a consequence of early conditioning of avoidance learning in a social context. This idea of suppressing of emotions we have further explored. What's interesting is that this has been recognized. I know Nancy is speaking tomorrow, and I saw her on the call today. This is a really groundbreaking paper, I think, that Nancy published in 1996, suggesting that the Black working class individuals who reported less exposure to discrimination had the highest blood pressure. So there are a number of possible explanations for this. Again, I don't have time to get into it, but we have replicated this finding repeatedly. So this is data from MIDAS, and we show that the Blacks have higher heart rate variability than whites. They have higher total peripheral resistance. But what's interesting is that those Blacks that reported lowest levels of discrimination, lifetime discrimination, had the highest total peripheral resistance. Similarly, those Blacks who had reported fewer exposure to lifetime discrimination had greater baroreflex sensitivity, another indicator of vagus nervous system function. So in a paper that is currently being revised for publication, again in MIDAS, we looked at this suppressing effect. We exposed Black and white individuals in the MIDAS study to images, negative, neutral, and positive images, and we measured their brow muscle, their sort of frown, negative affect muscle, the corrugator. And what we found was that Blacks, in response to negative and neutral images, had lower levels of corrugator activity. And we also indexed their self-reported suppression of emotion, and those individuals that reported suppressing their emotion more had less corrugator activity. However, the Blacks reported greater daily discrimination, but importantly, in the Blacks only, those individuals that had lower corrugator activity, that is greater suppression, they had the highest systolic and highest diastolic blood pressure. So this effect was found not only in African Americans and other minoritized ethnic groups, and some of the explanations that have historically been given for these ethnic differences include genetic differences, differences in diet, such that Blacks are eating more fatty and salty foods. So this is a study of lesbian, gay, and bisexuals in Rome. So they all were on the Mediterranean diet. And what we found was that, guess what? they also showed the cardiovascular conundrum pattern of elevated heart rate variability and elevated total peripheral resistance. And what we note is that this was particularly true for those individuals that reported fewer daily experiences of discrimination, victimization, and isolation. In a paper our group published, we found the same thing, that is, a negative or inverse association between incidence of discrimination and total peripheral resistance in pregnant African Americans. Again, we note the study from Nancy, and then Rodriguez and colleagues have found that a dysfunctional pattern of nocturnal non-dipping was particularly present in Black Hispanic participants with low perceived racism compared to those with high perceived racism. And they interpreted their results in terms of internalization of racism, where those with higher perceived racism may be more proactive against discrimination, possibly less likely to internalize their associated stress. So in conclusion, the default response to unsafety is the fight or flight response. This will show itself in elevated baseline levels, not necessarily an exaggerated reactivity. Safety has to be explicitly recognized, either consciously or most likely unconsciously, to turn off the stress response. And this shifts stress theory from a focus on threat to a focus on safety. And what we propose is that those minoritized individuals perceive their world as less safe and therefore produce a pattern of physiological responses in an attempt to keep this from destroying them, as Baldwin said. And I'd like to close with this quote: "Not everything that's faced can be changed, but nothing can be changed until it is faced." Thank you.
Thank you so much, Dr. Thayer. We will invite Dr. Thayer back to address questions during the discussion session. Next to speak is Dr. Rodolfo Mendoza-Denton, a professor of psychology at the University of California, Berkeley, who will be presenting on individual and structural sources of bias. Dr. Mendoza-Denton's professional work covers stereotyping and prejudice from the perspective of both target and perceiver, intergroup relations, as well as how these processes influence educational outcomes. Please welcome Dr. Mendoza-Denton.
Hello, everybody. I hope that you can hear me. Can I get maybe Dr. Garrido to confirm for me?
Yes, sir. We can hear you.
Great. Thank you. So I'll begin my presentation. I think you should be seeing at the moment maybe a blank screen.
Yes, except it's not in presentation mode.
Okay, here we go. Presentation mode. Great.
Yes.
Thank you. Okay, so I'm going to title my talk, oh boy, I am sorry. Okay. Forgive me. I'm having a little bit of technical difficulties here, and I don't quite know why.
I think you may want to play it from the beginning. Oh, there you go.
It's, yeah, not quite sure what is going on. At any rate, I really want to thank all of the prior speakers, and in particular want to hop off what the question that Dr. Galea posed for us about mechanisms, which then leads to the question that all of us have been, circling around, which is this idea of what drives our biases. I think it was Dr. Webb Hooper who mentioned that we can look at this question from various different sources or perspectives, or I should say, levels of analysis. And as a psychologist, a social psychologist in particular, I've been focused on the individual level, which fits very nicely into this etiology of bias. And I think the narrative, the national narrative around how to address bias has really settled on this individualistic approach. How do we put our biases in check? How does stigma, in my case, manifest at the individual level? And more recently, I've been challenged by this idea that Dr. Webb Hooper has spoken about of, how do we think about mechanism through the lens of context. So I'll begin with the work that I've done at the individual level, which gives us a clue about mechanism, which then can lead to a jumping off point for mechanism around structural bias, and that has to do with ambiguity. The model that I've been nurturing for about 20 years and has a long history before me with my advisor goes all the way back to John Bowlby, which is the idea of attachment. It's a very basic process where people try to essentially form interpersonal bonds. And this idea of interpersonal bonding really is at the root of so much of mental health, and conversely, when it's missing, mental health suffering. So Downey and Feldman developed a model called rejection sensitivity. And the idea behind rejection sensitivity, which was originally developed to try to explain difficulties in romantic relationships, is that one has prior experiences of rejection, right? Either from one's loved ones, through parents or through people who are important in their lives. And in then situations under which this idea of rejection or acceptance is relevant, people anxious expectations of rejection are activated. That means a concern that one is going to be rejected. What that leads to is this process that Dr. Galea referred to, this process of threat, not safety, right? Of vigilance, that one is going to be rejected. And so one is vigilant for these cues of rejection and is ready to perceive this noxious stimulus in the environment. And therefore, when one perceives it, leading to these very intense, hot reactions to perceived rejection that manifest both emotionally as well as physiologically. Now, in terms of the outcomes, and this has a lot to do with there's a lot of research on this. In terms of rejection sensitivity in the personal domain, this ends up being related to dissatisfaction in relationships, relationship breakups, and loneliness in particular, because this idea of being ready to perceive a threat in the environment, this rejection lowers the threshold for perceiving that rejection, and therefore can lead to difficulties in that interpersonal domain. And then we shifted the focus of that model to look at status-based rejection. In the first case, we called it rejection sensitivity on the basis of one's race. That is, am I going to be rejected within my environment on the basis of this characteristic, my race? And what we have found is that it leads to mistrust of a majority and its institutions, difficulty in the pursuit of valued goals in those institutions, and underachievement. Most of the work that we've done is in the domain of academics. I'm going to skip the slide in the interest of time, only to show you. I'll only make one point here, which is that this is for the scale that we developed for race-based rejection sensitivity among African Americans. And not only do you see mean differences here, but if you notice, there's also wide variability. In other words, some people very anxiously expect rejection on the basis of their race, and other people are quite calm about it and don't think about that at all. In contrast to what one might think, which is that, Asian Americans and whites do not experience or expect race-based rejection, that's actually not the case. The scale was made specifically for African Americans in this case. And when you develop a scale that addresses the contexts and the situations that are specific to each group, that's when those concerns come up. For example, for African Americans, being followed around at the store is a context that activates those race-based rejection experiences. For Asian Americans, not so much the case there, but in another case, being assumed that one is not socially competent. So there have now been several extensions of the RS race construct to reflect the different concerns, experiences, and situational expectations for various different groups. I'll go back to the race-based rejection example for one quick second, and just show here that what we have here is minoritized participants who are higher in RS race in a cross-race interaction show greater cortisol reactivity in the context of a cross-race interaction relative to their low RS race counterparts, but not so much so in the same race condition. What this shows you is that not only does the context matter in terms of the physiological responding, the threat responding, but also the individual differences. So the individual differences here being race-based rejection sensitivity. Let me show you an example here with respect to gender-based rejection sensitivity. And I love the study because it really begins to give us a small clue with respect to the mechanism that we can harness perhaps at the structural level. What we did here is we brought women into our lab and then we measured gender-based rejection sensitivity. That is, concern about being rejected on the basis of their gender. And we asked them to take a test in one of 3 different rooms. One was a room that had very clear signals that the person who was going to be evaluating them was progressive. In another case, and you'll see on the other side here on the right side, the cues were very much that their evaluator was going to be chauvinist. But then in the third room, the ambiguous room, the cues with respect to their evaluator, who was going to be, evaluating them, were ambiguous. And it turns out that those individual differences really came out in the ambiguous room. That is, people who were the women who were feeling secure did not differ as a function of RS race. They also didn't differ statistically when they knew the threat that was upon them. Right. This reminds us of Dr. Galea's quote from Baldwin. It's in the ambiguous situation that these individual differences emerge. Why is that? Because people are using their prior expectations, their prior schemas, to then disambiguate the situation. So we're beginning to see that ambiguity may play a strong role in the situational affordance for these expectations of rejection, these concerns to come out. On the flip side, can I ask Dr. Garrido how much time I have, please? Allow me to continue. Go ahead, please.
4 minutes. Yes.
How much?
4 minutes.
Thank you. So, couple more studies here. This is actually not my study. This is, and I love to show it because it's, it's not my data that's just suggesting this. We'll flip sides a little bit to the context, not of the person who is being perceived, but to the perceiver. What you have here is people who are rating white and black candidates' resumes and then recommendations for whether they should be higher. They had, as I said, a white candidate and a black candidate. It turns out that the CVs or the resumes were exactly the same. And you had 3 different types of resumes: a strong resume, a weak resume, and then kind of an ambiguous resume with respect to the strength for the job qualifications. And the data is very clear. Once again, in the ambiguous condition, that's when people's biases really come out, where the white candidate is seen as much more favorable relative to the black candidate, even though the resume and the qualifications are the same. Again, the mechanism is that we apply our pre-existing schemas to then disambiguate the situation. If you're a perceiver, that applies to how you evaluate others. If you are a person who is vulnerable or the target of discrimination, the same thing applies, except that you are then trying to disambiguate whether the context or the environment is safe for you or not. So, what does this have to do with the etiology of interpersonal bias? We've talked about the situation of ambiguity, but it turns out that ambiguity also has a lot to do with the context that we are in. Let me give you an example here. This is actually data from Charbonneau and Glaser in published in 2001, and it's a really interesting study about the U.S. Customs from U.S. Customs. Turns out that in prior to 1999, the U.S. Customs Agency had a list of 36 highly ambiguous criteria under which officers were allowed to make arrests to potentially have yield rates with respect to illegal substances or illegal crossing with respect to the border. And what you had here is you had disparities with respect to the number of searches, and huge disparities, particularly in the Latino population, with respect to the yield. In other words, greater numbers of searches for among Latinx participants, as well as lower yield. Come 1999, the rules were changed so that there were now not 36, but only 6 criteria that were actually very clear, right? So now there were things like, is the person sweating, or is the person having some kind of, thing that's bulging out of their shirt? And what you get is fewer searches, but greater yield and greater equity across yield. I have very little time, so let me just finish by saying here that we've conducted a university-wide survey at Berkeley showing the same thing, where across 31 departments across the university, what you get here is feelings of exclusion as a function of how ambiguous the rules and regulations and the expectations are within the graduate program. Turns out that there's a main effect of clarity. In other words, the greater the clarity, the less identity-based exclusion, and that effect is stronger for underrepresented students. And we also have some data for women as well. Let me end there, but by saying that ambiguity is a mechanism, but it's not necessarily a mechanism that is only residing at the individual level. It can exist at the level of the context or the environment in terms of the clarity of expectations, the clarity of outcomes, and the clarity with which we navigate our world. Thank you.
Thank you so much, Dr. Mendoza-Denton. Please remember to add your questions to the chat for the discussion section. Next to speak is Dr. Wendy Berry Mendez, the Charles D. and Dorothea S. Dilley Professor of Psychology at Yale University, who will be presenting on dyadic processes during interpersonal interactions, what physiological synchrony can teach us about prejudice and discrimination. Dr. Mendez's research focuses on how the brain and body respond to emotion and stress, using a variety of approaches applied to such areas as racial health disparities, stereotyping and prejudice, emotion and decision-making, and dyadic and group physiological synchrony. Please welcome Dr. Mendez.
Thank you. And I'm so grateful for the previous speakers who helped bring up some concepts that will also emerge in my talk today. And so just double checking that you can hear and see my slides.
Yes, we can.
Thank you.
Thank you. So today I'm going to take both a social psychological and health psychology approach to understanding interpersonal interactions with the ultimate goal of including people who are both perceivers or majoritized group individuals and the biases that they may hold, the target or the minoritized person in the interaction and the responses that they have by experiencing people's biases, and then the dyadic processes that occur when these people come together and interact. So typically a majoritized group approach is looking at stereotyping and bias, and typically will focus on white Americans who might be anxious during social interactions with different social groups that they might not typically interact with, like Black Americans. And these anxious interactions might be due to racial bias, lack of contact, discomfort, concerns over appearing prejudice. You just heard Rudy talk a little bit about this as well. The minoritized group approach is often focusing on somebody who experiences discrimination and rejection. So in this approach, we might look at Black Americans during social interactions with white Americans and ask questions about greater attentional vigilance, which you just heard about with race rejection sensitivity, maybe more threat reactivity that Julian Thayer talked us through, and more negative affect. The dyadic approach asks about the influence of bias on minoritized people and considers both people in the interaction. It seems really obvious and simple, but often research has only taken a majoritized approach or a minoritized approach and not considered these dyadic processes. The dyadic processes allow us to look at the interactive processes that individuals how they experience the interaction, and how the stress that might occur during the interactions can be transmitted and caught by the people in the interaction. So let's talk a little bit about the majoritized group approach and what that typically will look like from a social health psychology perspective. And I'm just going to give you a few examples of some studies that have been done to understand these kinds of approaches. So a series of studies that we ran in my lab with my colleagues is we would recruit white Americans to come into the lab, and they would interact with either another same race, same sex Confederate, a member of our research team, or a different race Confederate. So in this paradigm, we would have white Americans interacting with Confederates who were either white or Black Americans. During that interaction, we'll measure a variety of cardiovascular responses and look at the changes in cardiovascular reactivity during those social interactions. And I'll talk a little bit about what those physiological responses look like. We measure behavior. So how did people behave during these interactions? These are typically cooperative tasks. Did they cooperate well? We ask people about their attitudes, their stress. We have them rate their partners. How much do they like them and trust them? And we often would pre-screen on measures of explicit racial bias that you heard about in the beginning, intergroup contact, and implicit bias, typically things like the race IAT. So when we're measuring physiological responses, we use a variety of measures, but typically we measure things like impedance cardiography. This is a band electrode system that measures the amount of blood circulating in the thoracic cavity. We'll measure blood pressure and parasympathetic nervous system responses that gives us heart rate variability. So here's just some data from changes in physiological reactivity from our white participants as a function of whether the person they were cooperating with was a white American or Black American. So these are all very highly scripted interactions for our Confederates. They follow exactly the same script. So the interaction is the same. They're trained all together. But our white participants, unbeknownst to them, are interacting with an actor who has highly scripted responses. And what we see is that if you're white Americans who are randomly assigned to interact with a white partner versus a Black partner have decidedly different profiles of cardiovascular reactivity change. So what you see is greater ventricular contractility. So here it's a greater sympathetic nervous system response to white people interacting with a white Confederate relative to a Black American, greater cardiac output to a white partner, and more vasodilation. This is also related to blood pressure, so lower blood pressure when interacting with the same race partner, in contrast to a different race partner, which is more of the threat response, greater vasoconstriction, more blood pressure when the partner was Black American. We also see behavioral responses that differ depending on race, such that there's less movement, more freezing with different race partners. And what we see is probably an inauthentic response among our white participants, which is much more smiling. And this is actually the more threatened they are physiologically, the more they smile at their Black partners. Then we see the people smiling at same race partners. We also, as I mentioned, measure before people come into the lab about the amount of intergroup contact they experience. So this is specifically how much quality contact you have with people who are Black American and white American. And what you see here, the takeaway message is that the more intergroup contact people have with those from a different racial category, the less threatened white participants were during those interactions. So if you just want to focus on this TPR graph, the less TPR, the more the contact our white participants had with Black partners. We've also done studies where instead of using Confederates, we just have subjects evaluated by either a panel of white or a panel of Black evaluators. Again, in this study, all white Americans, and they were randomly assigned. Everybody had to do a Trier social stress test. What that is an impromptu speech and a mouth task in front of a panel of evaluators that look quite stoic. It's very evaluative. It activates the HPA system and the resulting cortisol response. But all we manipulated is whether that panel was all white or all Black evaluators. And what we found in this case is that people's implicit racial bias, their race IIT score, influenced both their threat appraisals, how they understood the situation, and their physiological responses. In this case, what I'm showing you here is white participants evaluated by Black evaluators perceived more or reported more threat appraisals when they were higher in race bias. So this is an implicit bias in which people have an implicit preference for white over Black. So more racial bias was associated, more threat appraisals. And while cortisol was high for everybody, so overall, everybody has a cortisol response to a Trier. But when we looked at a counterregulatory hormone that helps reduce cortisol, that's dehydroepiandrosterone or DHEA, we found that the more racial bias was associated with lower DHEA. So this is a more maladaptive response. So the more racial bias, the lower the DHEA when being evaluated by Black evaluators. We didn't see that association when being evaluated by white evaluators. So I'm going to leave majoritized group land and go to minoritized group research. So this is typically perceived, and these approaches take seriously the idea that racism is a stressor. And this experience of racism elicits a cascade of responses, physiology, and behavior that might be related to the mechanisms of ultimate health outcomes and help explain racial health disparities. Keely Muscatel and I, a few years ago, took this biopsychosocial model and charted the emotions that are likely activated in these experiences for minoritized individuals that then might help explain different physiological responses, different behaviors that might be health damaging, and how that might be related to health outcomes. But what do the studies in this space look like? Well, in one study, we recruited Black and white Americans to come to the lab. So now we're focusing more on Black Americans as participants. And now we're using white and Black Confederates. And in these studies, we're often manipulating people getting rejected in the laboratory. So we brought in white and Black participants who interacted with white or Black Confederates. They met each other, exchanged some information. They do a baseline period. And then we have the participant and the Confederate give speeches to each other on working together. Basically, what are you like as a person? And then the participant receives feedback from the Confederate in written form that's either very positive or very negative. Now, the Confederate does not know, they're unaware of the condition. But if you were a participant in my study and you were randomly assigned to a negative feedback condition, you would get this form that said your partner was neutral about being in a small class with you, was kind of neutral about being in a job with you, wasn't so sure about wanting to get to know you better, wasn't sure about being a roommate with you, and was fairly not too excited about being a close friend with you. So kind of subtle negative feedback prior to this cooperative interaction task where they then were face-to-face with this partner who either gave them very negative or very positive feedback. I'm going to focus here on the negative feedback. And again, what I think should be the take-home message here is that there's a strong interracial effect such that when people are paired with same-race partners who give them negative feedback, I'll just quickly interpret this for you. We see same-race rejection as creating a lot of threat responses. So sympathetic nervous system responses, a little bit of cardiac output, and more vasoconstriction. In contrast, when you're rejected by an out-group member, you generally are more approach-oriented and real quickly, more anger responses. So more external negative affect when you're getting rejected across the racial divide. We've also done this with avatars, with online studies, with studies in the lab, but being rejected by people presumably online. So again, same race or different race rejection. And what you see here is, again, more cortisol reactivity to same race rejection less cortisol reactivity to cross-race rejection that I think is inconsistent with people's intuition, but we find it over and over again. And it seems to come along down to these emotion lines. So more anger to cross-race rejection. When you're rejected by somebody from a different racial category, you tend to be angry, and more ashamed when you're rejected by an in-group member. I want to end with talking about these dyadic processes, or the extent to which people influence each other. And I hear the music, so I'll go right to the bottom line. We had people interact with each other and then measured their physiological extent to which they're influencing each other. So how one person's physiology influences their partner's physiology in the next time session. So if one person is more stressed, that their partner then would show more of a stress response. And I'm going to go right to the bottom line. And the bottom line is when white participants are more anxious, they have greater cortisol, they appear more anxious, they report being anxious, they are more likely to influence their Black partner. In other words, the more anxious a white participant is, the more their Black partner's physiological responses increase in that subsequent time interval. We don't see this effect when we reverse the model. So here's the summary of the effect. Everybody influences each other, but when there's anxiety, it's asymmetrical. White people's anxious responses influence their Black partner. We don't see the opposite finding. And the more Black Americans were high in rejection sensitivity that Rudy just told you about, the more they were affected by their white partner. And so with that, I'll go ahead and end by just saying that interpersonal processes matter, and we'd love to see the field move toward more dyadic interactions, as opposed to looking at people in sort of non-contextualized interactions.
Thank you so much, Dr. Mendez. Please remember we'll address the questions in the chat during the discussion section. Next to speak is Dr. Nao Hagiwara, who is a professor of public health sciences and director of the program on health disparities and community engagement research at the University of Virginia, who will be presenting on mechanisms underlying the link between healthcare providers' biases and minoritized patient health. Please welcome Dr. Hagiwara.
Great, thank you so much. Can you hear me okay?
Yes.
Great. Thank you. Thank my previous presenters for a great overview about the negative health consequences of interpersonal biases. And because my previous presenters focused more on the interpersonal biases beyond the healthcare context, my presentation will shift a little bit its focus, particularly to the interpersonal biases that happens while minoritized patients receive healthcare, particularly the biases of their healthcare providers. Now, I want to note my research so far has focused mainly on anti-Blackism and racial disparities in healthcare and health. So my today's presentation reflects that narrow focus. I want to start my presentation with acknowledgement of my collaborators and funders who have helped me develop my research program. And I want to give a special thanks to Dr. Spring and Penner, who have been my long-term collaborators, who, by the way, are both presenting tomorrow. This is a conceptual model that I use in my work. The definition of racial health disparities that I use in my research is systematic variations in physical and mental well-being due to inequitable economic, political, social, and psychological processes. Because these inequitable processes exist due to racism, I view racism as the root cause of racial health disparities. As Dr. Webb-Hooper articulated earlier, racism is complex and multifaceted construct, influencing individuals' health through both structural racism and interpersonal biases, which reinforce one another. At the interpersonal level, racism manifests in individuals' biased racial beliefs and attitude, which often results in discriminatory behaviors toward racially minoritized people. As discussed in earlier presentations, exposure to racial discrimination is a major stressor, and as a stressor, racial discrimination can directly compromise the health of minoritized people. healthcare providers are also exposed to racist ideologies just like other people. So they are not free from bias. And the research has shown that healthcare providers display racial biases that are at least compatible to the general population. And healthcare providers' biased beliefs and attitude have been associated with poorer quality of care for patients from those minoritized groups. Numerous studies have shown that compared to white patients, racially minoritized people, particularly Black people, often experience medical interactions that are less positive in content and tone, with shorter time spent on relationship building, treatment planning, and health information exchange. Black patients also tend to receive suboptimal treatments more frequently than their white counterparts. In 2003, the Institute of Medicine, the current National Academy of Medicine, published its seminal report on equal treatment. The report highlighted a critical role providers' racial bias may play in determining the quality of health care Black patients receive. Over the last 20 years, many studies have aimed to examine mechanisms through which provider bias contributes to the racial healthcare disparities. As Dr. Garrido has already discussed, interpersonal bias is not a single-dimensional construct. A recent review has shown that it is important to distinguish these 4 forms of bias when predicting the nature of racial healthcare disparities: explicit stereotyping, implicit stereotyping, explicit prejudice, and implicit prejudice. Stereotyping is the cognitive component of bias. It refers to people's beliefs or expectations about a certain social group or its members. Prejudice is the affective component of bias. It refers to people's negative feelings toward a social group or its members. And both stereotyping and prejudice can operate at explicit and implicit levels. Overall, our review suggests that biases among healthcare providers mainly manifest in 2 specific healthcare during medical encounters, which is clinical recommendations and patient-provider communication, which in turn can impact patients' physical and mental health status in the longer term. And in the next few slides, I will review how each of these 4 components of bias is related to these 2 specific aspects of healthcare. And I will start from the top. One consistent finding from our review was the role of explicit negative racial stereotypes in suboptimal clinical treatment or recommendations for Black patients. For example, one study has shown that healthcare providers are just like other people. They hold, or at least are aware and report, the societal negative stereotypes against Black people, such as Black people are less educated, have lower levels of health literacy, and are less likely to adhere to treatment recommendations. Research has further shown that these negative stereotypes are associated with their initial treatment recommendations. For example, healthcare providers and trainees who falsely believed that Black people are biologically different from white people were less likely to be accurate in treatment recommendations. In contrast to the association between explicit stereotypes and clinical recommendations, there is little research that examines the role of explicit stereotyping in patient-provider communication. So this is one literature gap that needs to be addressed. And next, I will turn to implicit stereotypes. Unlike research on the role of providers' implicit prejudice, which is the last form that I will review, studies on providers' implicit stereotyping remains limited. Although more studies are beginning to explore the levels of implicit stereotyping among providers, very few studies have actually investigated its impacts on racial healthcare disparities. So these 2 dotted lines are additional literature gaps for the future research. Next is the role of explicit prejudice. Our review suggests that providers' explicit prejudice plays little role in either clinical recommendations or patient-provider communication. The expression of racial prejudice is strongly condemned in medicine. So we generally observe little variability in explicit prejudice among providers when we assess it. Lastly, the role of implicit prejudice. Our review revealed that providers' implicit prejudice is consistently associated with the quality of patient-provider communication. Specifically, providers' implicit racial prejudice is associated with multiple nonverbal and paraverbal behaviors, which are listed here. For example, providers with higher as opposed to lower levels of implicit prejudice tend to display behaviors that signify social dominance, such as greater number of utterances and a greater talk time. Interesting, however, while they dominate the interactions, physicians with higher levels of implicit prejudice tend to have shorter appointment with Black patients. Providers with higher levels of implicit prejudice were also found to use first-person plural pronouns and anxiety-related words more frequently when interacting with Black patients. When interacting with Hispanic patients, they tend to use interrogatives and work-related words more frequently, and prepositions and relativity-related words less frequently. Finally, providers' implicit prejudice has been also found to manifest in providers' unstructured notes in patient medical records. Turning to the role of providers' implicit prejudice in their clinical recommendations, our review revealed no evidence to support it. However, a recent study has shown the bidirectional causal relationship between implicit prejudice and implicit stereotyping, so it could possibly exert its effect on clinical recommendations indirectly through implicit stereotyping, which is again yet to be tested empirically. Another area of future research opportunities is the potential interactive effect between explicit and implicit prejudice in predicting the quality of patient-provider communication. Because explicit and implicit prejudice are independent constructs, people can score high on one and low on the other. In fact, many non-Black people in the United States score high on implicit prejudice, but low on explicit prejudice. And this pattern of implicit and explicit prejudice combination is referred to as aversive racism. Individuals who fit the aversive racist profile are often perceived by Black people unfavorably because they tend to say positive things, while their nonverbal and paraverbal behavior tend to signal psychological distance. And these inconsistencies in behaviors are perceived as unauthentic. And consistent with these findings from previous basic social psychology research, there is evidence to suggest that healthcare providers who fit the aversive racist profile were perceived as the least positive by both Black patients and independent coders who observed the video recorded interactions between Black patients and providers. To my knowledge, there are only just a few studies that have examined this interactive effect between implicit and explicit prejudice in the context of patient-provider communication. So this is another literature gap that should be addressed. Taken together, the solid lines represent what we know in the current literature, whereas those dotted lines represent what we still need to investigate empirically in order to gain a more comprehensive understanding of the role of provider racial bias in racial healthcare and health disparities. And finally, I want to go back to the reciprocal relationship between systemic racism and interpersonal biases that I mentioned at the beginning. Individual bias is closely tied to systemic racism at institutional and community levels. For example, the inclusion of race in medical algorithm is one form of systemic racism. It reinforces the endorsement of a stereotype that Black people are biologically different from white people, which is a form of individual bias. So eliminating racial healthcare disparities that are attributable to provider bias still requires a multi-angle, multi-level approach. Thank you.
Thank you so much, Dr. Hagiwara. We will now transition into the discussion portion of our session. Joining us in the role of discussant is Dr. Janet Tomayama, a professor in the Department of Psychology at the University of California, Los Angeles, and director of the Diet, Stigma, and Health Laboratory. Her research focuses on the biobehavioral and health consequences of stress, dieting, comfort eating, and weight stigma, with consideration to low socioeconomic status and food insecurities. We now welcome Dr. Tomayama to provide a few remarks and lead us in a spirited discussion on the etiology and mechanisms to elucidate the link between interpersonal biases and health.
Thank you, Dr. Acevedo, and thank you all for being here and for inviting me. We have until 2:40 to talk about these questions. There are already some great ones in the chat, so I'm just going to talk about a couple of things that struck me. And the first thing I want to do is really express my appreciation for these 4 amazing talks from absolute leaders in the field. These talks were really sophisticated, which I really appreciated because it means we're going beyond just bias is bad for health and really getting into the mechanisms through which bias is affecting health. So Dr. Thayer's guts model is a beautiful example of this. His work focuses on the cardiovascular system and highlighting the role of peripheral resistance. Dr. Mendoza-Denton showed us some data on the hypothalamic pituitary adrenal, or HPA axis, but there's also other really important work in the field that identifies other pathways like inflammation, accelerated aging, epigenetics, even microbiome pathways. So we've really only scratched the surface here in terms of pathways. I was also struck by some surprises in the data. So, things like, actually Black participants have higher heart rate variability, as we saw from Dr. Thayer's presentation, or that, you don't see evidence of prejudice in weak cases. It's in these ambiguous cases like Dr. Mendoza-Denton's work. I was surprised to see this finding from Dr. Mendez that you see actually more smiling from white Americans when interacting with Black Americans, and that the Black Americans are having more reactivity to the same race rejection. And then also another surprise in Dr. Hagiwara's presentation was that there wasn't really a link between implicit prejudice on actual clinical recommendations. And I know, I think it's Katarina who has a question later on implicit work. And so I really think this is why we need to do the work. And this is why we need to publish the work. And we need to publish the work even when the findings are null findings or contrary to hypotheses. And I think the use of open science practices like pre-registration will really help pave the way for these surprise findings. I also think it's helpful to use a framework that I learned from Brenda Major and Bruce Link, who are, of course, leaders in this field, talking about the difference between enacted stigma versus perceived or experienced stigma. So I think we're used to thinking of perceived or experienced stigma always, where the patient, in the case of Dr. Hagiwara's presentation, who's really shaken by a stigmatizing encounter. But I think it's also really important to remember that we can have enacted stigma, where a patient or a participant perceives no stigma whatsoever, right? They're fine. And yet they can still have poor outcomes because the provider is acting in discriminatory ways and the provider is delivering less optimal care. They have the interpersonal biases, and that can harm health even in the absence of a person actually experiencing or perceiving interpersonal bias. So I think it's really important to capture both sides of that. And then I think the picture becomes even more complex with Dr. Mendez's really fascinating work on synchrony. So, now we can, in quotes, catch threat and stress responses with, as always, the minoritized group member incurring the costs. And turning to Dr. Mendoza-Denton's presentation, I wanted to add that I've also used the concept of rejection sensitivity in the weight stigma sphere. We're going to hear more about weight stigma from Dr. Mary Garend in her flash talk tomorrow. And this brings me to my final point, which is that we really can't understand each type of interpersonal bias in isolation. So Dr. Thayer showed us some data on this, but a person can be a Latina woman who simultaneously has higher weight and lower socioeconomic status. And I think the field's really grappling right now with what are the best methods to examine intersectionality, particularly quantitatively. I think the theory on intersectionality is strong and it's there, but we really need to advance the methodological work as well. And that's why I'm really grateful to the organizing committee for its emphasis on methods and Dr. Webb Hooper's remarks on measurement. And I'm really looking forward to the rest of the workshop. So let me turn to questions. Since I have the microphone, I'm going to use this privilege to ask the first question, which is something I saw on Dr. Webb Hooper's list as well, of questions she's listening for the answer for, which is how universal are these processes underlying interpersonal bias? Is it a general model like the GUTS model that we just apply to whatever minoritized groups like race, or in my case, weight? Or do you think there's ever a time when a specific group warrants their own specific theoretical model and theoretical approach? I will open the field to whomever wants to take that one first.
I can chime in on that one, Janet. Thank you for your insightful comments. In our context, we have been showing this across different continents, across different stigmatized groups, and finding some similarities. But, your colleague, David Sears, has written about Black exceptionalism, for example. So there may be the necessity for certain specialized approaches. But again, I think the research is not there yet. As you rightfully pointed out, in particular, looking at the intersectionality and how you identify ethnicity and all these things are real challenges in our work, trying to put people into sort of categories is really problematic and quite tricky. No ethnic group is a monolith. So looking at all those subtle differences, it's a real challenge. And, currently we've been using, the federal recommendations for how to identify race and ethnicity, and they're not adequate for our research purposes, actually.
Wendy.
Yeah, it's a great question, and I actually really appreciate Julian's comment. I do think there are some basic principles that might be useful, but we almost have to step back like 50 years ago to like Irving Goffman's stigma concept, where not all stigmatized identities are the same. And so there's the controllability versus non-controllability. I think of your work, Janet, like the extent to which people are perceived to have control over their weight versus not. How does that influence? But then I love Julian's GUTS model because it does provide some general framework. And then within that general framework, yes, I think there's going to be individual categories. I don't think they're so vast and infinite that every category will be the same, but there's going to be ways to organize it either along like Goffman's, like I said, half a century old way to think about stigma and how that identity sort of it comes to be known, and do people have control or not. So it's not completely impossible to solve, but you need both broad and then specific models.
Thank you. So I'm going to prioritize the questions that basically any of you could answer. I think we get a lot of meaning in hearing different perspectives. So I'm going to go to Aishat Sadiq's question. As a researcher, how do you balance the focus on individual level measurement and its impact on personal outcomes with this recognition that societal level change is needed to really alleviate the burden on marginalized individuals?
I'm happy to start off the discussion again. This is a real challenge because part of the historical problem is that we have, I think, had a tendency to blame the victim in a lot of cases. And that has to be represented in our research approach, not to do so, and to view it, as Keith Whitfield cogently wrote, as a cultural, not a cultural deviant model, as has historically been taken, but a cultural variant model in which these responses are adaptive in the context that those individuals find themselves in. And I think that that automatically implies sort of an individual environment interaction, such that it cannot be placed in one or the other. In the context of some of the things that I talked about today, it's interesting that it was the individual perceived safety and not the actual neighborhood safety that was associated with the blood pressure changes in that differences in that one study. So I still think there's a lot to do with the individual. However, it's clear that safety is a structural issue that can be addressed. And that leads us into policy. And I think in the context, for example, of things with climate change that I know that many societies are working with, it's encouraging us as investigators to become more active in policy discussions.
Great. And
I'm
Rudy, I
happy
saw you.
to, I'm happy, thank you. And I really appreciated the question. In fact, I saw it earlier, was eager to speak about that. So I mentioned this a little bit in my talk, but you know, there is such a strong bias, I think, in our popular culture towards the individual approach, right? And so, you know, what are and I think that's even reflected in how we conceptualize our own models. I'll take you back to 2018 when two Black patrons ended up being arrested in Philadelphia, which led to a day of closure at Starbucks, much to the dismay of the caffeinated. And the solution was bias training for everybody. Now we know that bias training has little to no effect, and if there's any effect, it tends to be short-lived. Again, because it's an individual level approach. But the news of what happened, if you remember, is that there was it came out later that there was no guidance for managers on what to do with non-paying patrons. Again, this ambiguity idea that allows for the expression of prejudice. You have to include the individual level because individual differences happen, as you know, as Dr. Thayer said. You know, so the perception of what, you know, it really gets into, you know, is part of what matters here, and Dr. Tomoyama's distinction as well. But structurally, you can do things to facilitate or, you know, or try to level the playing field so that there's guidelines and procedures.
Thank you. Now.
Yes, so this is a great question, and I always remind myself, like, so I was training as a social psychologist, now in public health area, the reinforcement between structural racism and individual level biases, I think that's what's lacking in many of the research framework. And going back to the research framework of NIMHD's Dr. Webb Hooper shared at the beginning, it's continuum. And if you are lacking one, then you are not being able to comprehensively reduce health disparities and achieve health equity. So it's not that we cannot focus on individual level or we cannot focus on just systemic racism structural level. I think it's the importance of acknowledgement that there is a relationship among all these levels of factors, and then considering that relationship, what's the best approaches at the individual level to address the issues at hand. But at the same time, when we are focused on individual level within the context, we also need to be mindful of what it means from the community's perspective. So CBPR approaches is really critical when we are developing individual level interventions, the community-based participatory research.
Now, since I have you, I might have you respond first to Katerina Abushan's question in the chat, which is, to what degree should we continue to study implicit bias and prejudice and associations as opposed to focusing on explicit bias, prejudice, and behaviors? So what is the implicit side's utility when designing interventions? I know you've spoken on this before. I want you to wade into this, please.
Right. So I think we should assess both because again, there is some evidence to show that it might be the interactive effect between the two. And focusing on implicit prejudice, what providers bias per se, I think its utility is to know how it manifests behaviorally when they are interacting with patients. But once we identify that, in a conceptual model, I see that behavioral manifestation as a mediating between implicit provider's bias and the patient-centered outcomes or patient outcomes. And then we can really focus on intervening the negative consequences of bias as opposed to trying to reduce bias among providers, because we know from, lots of research, like the last 40, 50 years of research in social psychology, it's really hard to reduce individual level bias without intervening in the structural level biases. So that's how I see the utility of still focusing on bias as what it leads to behavioral outcomes.
Great. And Wendy, I know you also use implicit measures as well.
Yeah, I mean, I think this is also part of like a pendulum swinging too far, reaching us from one side to another, because I completely agree with now. I think there's a lot of utility that one could get from implicit or automatic or physiological responses that complement explicit bias. And I think implicit bias, when it first came out, because it's in some ways not threatening. It was a way to say, introduce a racial bias to people and awareness, where it was like, oh, okay, it's not my fault. So I think it had maybe some utility there, but as the only outcome for changing behavior, I think it's problematic. It's not clear whether changes in IIT bias actually really tell us anything about sustained behavior, but we want some way to sort of gauge change. And I think the answer is going to be that the hardest outcomes, which is the behavior, the actual patient outcomes and patient treatment, has to be our North Star. And how we get there might change because we have a variety of tools in our toolbox.
Okay, I got a direct message from Troy Dildine. So for some of the topics being studied, like prejudice and health disparities or medical mistrust at the individual context, this is a methods question. How do we get those experiencing the worst circumstances to participate in research? So, people with super high medical mistrust are not going to want to be in a study on, doctor-patient interaction. So do you have, in your collective decades and decades of running studies, any thoughts on this?
Well, in the years I spent at the National Institute on Aging, one of the things that we came up with was mobile research vehicles, where we went out into the community. Because at the time, we were at the Johns Hopkins Bayview campus in Baltimore, and people basically said, the Black people would say that if you go to Hopkins, you don't come back, kind of thing. So it was really quite stigmatized. So our response was to go into the community. And again, this gets into the community-based participatory research idea. And I think that is one way to get around it. The other way is something I know that Wendy has done a lot with, which is using sort of mobile devices to collect data in people's real life settings and utilizing that type of data. So I think that with modern technology, there are ways to address that issue a bit more, but it's still quite a problem.
I'll just say my own research, it's really hard. UCLA is on the west side of Los Angeles. It's a very affluent area. It's really far from the more lower SES and more Black and brown neighborhoods. And so I think it is a challenge. And I also do want to highlight attention. I mean, I agree that community-based participatory research is in many ways the answer. I think it's a little bit risky for more junior investigators to engage in that kind of work because it takes a long time and it's really difficult, and you have to spend a lot of time making these relationships with the community. And so kind of the talking about structural processes, I think the incentive structures for those of us in research and academia are kind of misaligned with the types of methods that need to be used for this really important work. So I'm going to take the last 40 seconds here and thank our speakers and thank Amanda Acevedo for moderating. And I believe we are headed into a break, but I'll turn it back over to you, Carlos.
Thank you. Thank you all for your questions and engagement with this session today. Please join me in thanking our speakers and discussants for their presentations and their insightful discussion. As the time is now 2:40, we'll move to a short break before our next session. Please return at 2:45 Eastern Time so that we can begin session 2. Thanks.
Good afternoon, everyone, and welcome back from the short break. My name is Dr. Dolly Penn White, and I am a primary care physician and program official in the Division of Clinical and Health Services Research at the National Institute on Minority Health and Health Disparities. And I will be moderating this session titled The Clinician Perspective on Addressing Interpersonal Biases. We have 4 amazing panelists that I will introduce. First, Dr. Alicia Fernandez is Professor of Medicine at University of California, San Francisco, UCSF, a general internist at Zuckerberg San Francisco General Hospital, and Associate Dean of Population Health and Health Equity for UCSF School of Medicine. She's the founding director of the UCSF Latinx Center of Excellence and directs the Latinx and Immigrant Health Research Program at the UCSF Center for Vulnerable Populations. Next, Dr. Cristina Gonzalez is Professor of Medicine and Population Health and Associate Director of Medical Education at the Institute for Excellence in Health Equity, New York University Grossman School of Medicine. Next, we have Dr. Johnson, a tenured Associate Professor of Emergency Medicine at the University of California Davis School of Medicine. And finally, we welcome Dr. Brandon Velez, an Associate Professor of Psychology and Education in the Counseling Psychology Program at Teachers College, Columbia University, and the Director of Clinical Training for TC's Counseling Psychology Doctoral Program. We invite you to view the bios online for more information about our panelists. So thank you, panelists, for joining us today. In order of introduction, we will start with asking each of you to provide a 3 to 5 minute overview of your scientific and clinical work related to interpersonal biases in health. So we'll start with Dr. Fernandez. I don't see her showing here, so we will start with Dr. Gonzalez.
Hi, good afternoon and potentially good morning still to some of you. My name is Cristina Gonzalez. Thank you so much for the introduction and for inviting me to be a part of this wonderful day. I am a hospitalist in internal medicine, and my research focus is on designing, implementing, and evaluating skills-based interventions to help us all as clinicians recognize and manage the impacts of implicit bias on our clinical encounters. And so since my medical education research fellowship, this has been practically my singular focus, and we work on, my lab developed the framework of implicit bias recognition and management. And what that is exactly what it sounds. It's teaching us all to be able to recognize when implicit bias may be impacting an encounter then taking a step back, thinking through the encounter more purposefully, implementing the skills that you would learn in the interventions, and then seeking to deliver the excellent care you wanted to give in the first place. And as I was listening to some of the talks earlier, I was thinking that it really does work on takes a dyadic approach. I don't know if it formally meets the definition of our previous speaker, but it accounts for perceived and actual bias, meaning that I may be asking as a physician a question that I perceive as routine, but the patient, based on their lived experience with bias and discrimination, may perceive that as stigmatizing or discriminatory or biased. That can affect the encounter, even though technically I didn't do anything wrong. And so with our patients, we were able to get their suggestions for how to restore rapport when bias has been perceived. And also, of course, it accounts for when I'm a human and I make a mistake and I make an assumption or I do an activity or an action, that I would rather not have in hindsight. And the reason why we've stayed focused on this approach is that it doesn't seek to change our biases, because there's not evidence that changing your bias actually will change your behavior. There's a lot of evidence saying that it doesn't actually do that. And so, but it gives us the ability to have that aha moment, depersonalize the event, partner with the patient, and seek to restore the rapport and the communication skills to be able to optimize the outcomes. And the last thing I'll say is that it's centered on racial bias, because before 2020, nobody wanted to talk about racial implicit bias, but our early data show that it goes across constructs. So imagine if I'm your patient and the vibe changes, the rapport, my nonverbals and communications kind of changes toward you. You don't know if it's because I'm Puerto Rican, I'm a woman, I'm Catholic, my BMI is blank today, but you know something changed. And so that's where we're really excited to help people get the skills to lean into that change and partner with patients to really be able to work together in that dyad. Our next step is the diagnostic process, but hopefully we'll have some exciting outcomes in a couple of years. But we're really excited for our simulation skills-based approaches thus far. Thanks for having me today.
Thank you so much, Dr. Gonzalez. It looks like Dr. Fernandez is now on camera, and hopefully you can unmute and give us a short introduction, followed by Dr. Johnson and Dr. Velez. I won't come back on. You all can just follow each other.
Thank you very much. Can you hear me okay? Great.
Yes.
So thank you for inviting me. It's a pleasure to be here. I think to introduce myself and my work, I'll just talk about two things. One is that I do a lot of work on language barriers in healthcare. And one of the ways in which interpersonal biases play into that is the underuse of interpreters. Everyone is very familiar with the fact that people will, quote unquote, skip the room. Oh, we'll come back to that patient when the patient speaks another language, and of course they don't come back. Or with just going in and doing an exam and not talking with the patient at all. So I think it's really helpful to examine this phenomenon as part of interpersonal biases, because I think we do it because we value those patients less. We think at the end of the day, it's okay to cut corners. People, we've done research, it shows that people know that they're cutting corners, they know it's not fair, they kind of have mixed feelings about doing it, the regret, but they do it. And I think that it's very helpful to bring in that example to a discussion about interpersonal biases, because it really highlights the need for structural solutions to what are often perceived of as interpersonal problems. In other words, if there were policies, documentation requirements, and audits on a minimum use of interpreters for, say, hospitalized patients, then perhaps we could address it. So that's one sort of line of research. How do we recognize when what are the structural issues that can change the ways in which we as clinicians play out our interpersonal biases? The second line of research has to do with, I did a lot of research with some colleagues a few years ago on dealing with racist patients and collected a lot of information about patients not accepting care, and all the way down to the sort of unfortunate remarks or jests that patients sometimes make that are clear microaggressions and are targeted around clinicians' ethnicity or race. And if people, I don't want to take the focus away from what we do with patients, but that is another line of work that I am happy to discuss.
All right, I will go next. Thank you so much, Dr. Penn White, and to the rest of your colleagues at the NIH for inviting me. My name is Tiffany Johnson. So to introduce myself personally and professionally, so I'll start with personally. And I always like to kind of anchor who I am in saying that I am the great-granddaughter of Serena Smallwood, and I am the granddaughter of who I refer to as the original Catherine Bell, and I am the daughter of Kathleen Smallwood Johnson. I'm the favorite sister of the second Catherine Bell, and I'm also the best auntie ever. And I think that introduction and that anchoring is important because I'm someone who was raised by a single mother and her amazing village of phenomenal Black women. And I'm also someone who is a product of an urban under-resourced public school system. I'm someone who's experienced more than 4 ACEs, which many of you know is linked with many adverse health outcomes. And it is this background of these lived experiences that I bring to my professional experiences as well. So professionally, I'm a pediatric emergency medicine physician. And so I'm so excited to be here representing the voice and the perspective of children and adolescents in this country. And my research is focused on race and racism and its impact on child health. So as mentioned by Dr. Gonzalez, prior to 2020, this work wasn't quite as popular. And so when I first began my research, I really had to start with that Kilgore model of disparities research of identifying, understanding, and reducing, and really had to do that foundational work of identifying disparities. Because when you think about that initial unequal treatment report that is now being revised, out of the hundreds of articles included in that report, only 5 of them looked at disparities in pediatric populations. And so pediatricians like to think that we are superheroes, which we are. We give high fives and hugs instead of handshakes, but we are not immune from having bias, and we're not immune from disparities in pediatric healthcare. So a lot of my initial work focused on proving to pediatricians that yes, disparities exist even in pediatric populations. So looking at some individual studies at an institutional level, doing some work with PCAR and the Pediatric Emergency Care Applied Research Network to show among 18 top tier children's hospitals in the country that disparities exist, and also using some other national data sets to just identify disparities in pediatric healthcare. And then I pivoted it into work focused on understanding the root causes of disparities. And so that includes a lot of work looking at implicit bias as well as other various forms of racism and how they impact child health and development. So a lot of my early work in implicit bias was again to prove that similar to the general population, even pediatricians who are superheroes also have similar levels of implicit bias as the general population. And they not only have similar levels of bias in general, but even bias towards children, which I was personally surprised by. We have just as much bias towards children as we do towards adults that impacts their health outcomes. And now I'm in a phase where I'm more focusing on how do you focus on what are some of the interventions in order to reduce some of those disparities in care. So thanks again for having me. And I'm excited to be on this panel with these all-stars and look forward to this great discussion.
Hi, everyone. Thank you. I feel so humbled to be part of this really wonderful group of scholars. Following the last introduction, I would hope that I can call myself the best uncle or tio to my niece and nephew. So I'm Dr. Brandon Velez. I'm a counseling psychologist. I know many of the people on this call are physicians, so I will provide a little bit more information about my professional context. I am an associate professor in the counseling psychology program at Teachers College, Columbia University, and I'm also the director of clinical training for our doctoral program. Our program has a quite large master's program, so we have about 100 to 120 master students in either mental health counseling, who when they graduate become licensed as mental health counselors and school counselors. And we also train counseling psychologists to be licensed psychologists. My research has predominantly focused on documenting the ways that different forms of discrimination, objectification, or marginalization are associated with different types of mental health or body image, and also career outcomes. I've been particularly interested in looking at the ways that multiple forms of oppression or marginalization work together to shape the well-being of populations like people of color or sexual minority people of color, women of color. More recent areas of interest for me have been trying to look at some of those outcomes, move the research into more of a clinical context. So more recent research has examined, for example, transgender and non-binary people's perceptions of microaggressions with their experienced with their clinicians, and to document those associations with important psychotherapy process and outcome variables like the Working Alliance. And I have also begun to become more interested in documenting psychologists' perceptions of the social justice training that they receive in their graduate programs or are sharing with their graduate trainees. So thank you. I'm really fascinated to be part of this panel.
Thank you all again. So since we're done with the introductions and your brief, summary and introduction of yourself, we will now move into some discussion questions. And there are some that are for everyone. There are some that I will direct to a specific panelist. But however, if you have some kind of response or you want to have a follow-up question, this is a discussion, so feel free to jump in. I want to just be the facilitator, and we want to learn from you all. And so the first question is for any and all panelists, and it has two parts. You will see a theme that most of the questions have two parts. So the first part of the first question is, in what ways do interpersonal biases manifest in clinical settings? And the second part of that question is, what strategies have proven effective in mitigating the negative effects of interpersonal biases on patient care?
All right, I'll go ahead and jump off and talk about children in the pediatric perspective. So overall, similar to one of the earlier presenters who showed that when we look at resumes, when there's ambiguity, that's when your biases are more likely to come out. In pediatric healthcare, we see the same thing. So whenever we see an area where there's clinical uncertainty, that's when we tend to rely on our heuristics, which can include bias and stereotyping. So for example, in research looking at head CT use in children, we found that among the kids who were the sickest of the sick with an abnormal GCS, who had an abnormal insul status when they came to the ED, whether you were Black or whether you were white, you got a head CT. But it was among those kids where it was kind of, they had an intermediate injury, where we see more CTs being done in our white patient population in comparison to the Black population. And when providers were asked what was the number one factor driving that, they said it was parental concern. And so that theme of we identify these concerns among parents and we want to address them when the parents are white, but not when the parents are Black, is something that we see throughout pediatric healthcare. So that's also true for when we look at children who are under 2 years old, who can't talk, who come in with fractures. And when there's clinical uncertainty about was this fracture caused by an accident or was it caused by abuse, we see that Black children are more likely to be worked up for abuse and referred to Child Protective Services. White children are less likely to be evaluated and worked up. So these kind of bi-directional disparities that, sometimes more care is not better care, and it has negative outcomes for both of our patient populations. So those are just a couple of examples that we see in pediatrics. In terms of which strategies might be effective at mitigating them, it's how can we develop better clinical decision tools in order to reduce that clinical uncertainty to take out the role of heuristics in our decision making. So for example, PCARN helped develop a head CT decision rule that helps you objectively determine which children are high risk that should get a head CT when they come to the emergency department. Similarly, I'm partnering with an investigator right now, Mary Clyde Pierce at Lurie Children's, in an NIH funded study to develop a clinical decision rule for children under 2 who present with fractures to help identify which ones are higher risk for abuse that we should perform those evaluations for, in an effort to help reduce some of those biases that come into play.
I'd like to add to that, there's a lot in terms of it. I don't want to reiterate what Dr. Johnson just said because but I agree with it all. And I think that, as usual, and I think that the biggest thing is the point about ambiguity, because oftentimes we do studies and people are trying to do studies to see if implicit bias impacts this or it impacts that, but there is no clinical ambiguity. It's a bone-on-bone knee x-ray and everybody gets a knee replacement. And so, I'm an adult internal medicine doc, so my examples are often the internal medicine field. So I think that the ambiguity is big. I think just the way that we're socialized, so the way that it manifests, we heard a lot about the etiologies, but in terms of manifesting this interpersonal distance, so you're further away from Black patients. If we're going to keep it race, centered on race, but this, the data are similar when they have been studied across various constructs, and of course, nobody's a monolith, but there's greater interpersonal distance as a result of implicit bias. There's more cutting people off. There's more verbal dominance, so the physician spends a lot more time talking compared to the patient. There's less shared decision making, so the patient's input isn't even sought as often when they're from a marginalized population. And so I think that it's a hard question to answer, Dr. Penn-White, about what are proven strategies. So I'll say what we've been working on, and I did not mean to give you stress by going off camera. There's a 12-hour window for my refrigerator to get fixed, and they're here right now. And so I'm so sorry. And so I think that one thing that we've learned from patients, from our patient focus group studies, and thankfully over and over and over again, is that when you notice that change that we talked about, that change, either, maybe I sit back like this, or as the patient, maybe the patient gets quieter, maybe all the things we do in regular life, when we're having a regular conversation and we realize that the vibe or the feel or something is now off, when previously everything was going okay. When we got our patients to talk about it, this was focus group studies with Black and Latinx patients in English and Spanish, and we went all over New York City to talk with people. And when we finally got them talking about it, I said, what should I teach myself and the medical students, because that was my audience at the time, to do when this happens? And they were like, just apologize. I was like, I'm sorry, what? They were like, just apologize. And I was like, oh, well, that I can teach. So we often say we didn't invent the skills to restore rapport when bias is perceived by patients, but we worked with patients to highlight and make super crystal clear what it is we need to do. It's the ignoring that is that second insult, right? So thank goodness you're so generous and don't expect us to have perfect bias-free encounters all the time, because they recognize we're human. I couldn't believe how generous the patients were when they talked about physicians. But we do need to do is be humble ourselves and recognize when the rapport or the interpersonal vibe has changed, and stop and check in and partner with the patient and let them lead in how they want to proceed, and acknowledge it, whether it's I myself made a mistake or I'm apologizing on behalf of the health system. I'm the one that can apologize as the physician in that moment.
To follow up on Dr. Gonzalez's excellent point, and I'll speak specifically about the psychotherapy context. There has been a really watershed study of the influence of racial microaggressions on the Working Alliance in Psychotherapy, found that, as expected, perceptions of racial microaggressions perpetrated by the therapist were associated with clients or patients' negative perceptions of the Working Alliance, which is an important predictor of positive psychotherapy outcome. What I think the most interesting part of that study was that among about half of the participants had experienced a racial or ethnic microaggression from their therapist. And of those half of them had talked about the incident with their clinician. And the study found that those clients who had discussed the incident with their therapist, their levels of the working alliance were similar to those who hadn't experienced a racial or ethnic microaggression at all. So the authors of that study interpreted the racial or ethnic microaggressions as just in psychotherapy as a specific form of the therapeutic rupture, and drew upon the literature on the importance of addressing ruptures when they happen in order to enhance the working relationship. I think the difficulty there is if biases are unconscious, how does the clinician know that a microaggression has occurred? And I think that speaks to a larger issue in the multicultural competence literature, or actually the competence literature more generally, that psychotherapists often don't receive feedback on their work. They are working with clients, and then after they are licensed, the feedback that they receive is often whether or not clients come back to work with the clinician. So I think that speaks to the importance of regular monitoring of what is going on in session, perhaps like after session, doing check-ins with clients about their perceptions of the relationship more regularly to be able to identify when, perhaps a rupture has happened.
I'll jump in as well and say first that how much I agree with everyone else on the panel, both in terms of the role of uncertainty, also in terms of the importance of apology, and also with one of the points that Dr. Gonzalez made in terms of that she's amplifying in the chat, that changing scores doesn't necessarily result in changed behaviors or and even more distally changed outcomes. So I want to just talk about how we need to how we need to continue to match structural change to individual change. So for example, a nice experiment was done some years ago at the Brigham in clinics in Boston, where they taught primary care physicians about implicit bias and about health equity as it relates to both hypertension control and diabetes control. And at the end of that, the clinicians had heightened awareness and they had heightened knowledge, but the measures, hypertension and diabetes, did not change. This is Sequist is the first author on this, Thomas Sequist, and what I took from that, and conversely, what we have are situations such as at Kaiser in Permanente in Northern California, which has done a pretty good job of addressing hypertension, black-white inequities. Not perfect, they still have some, but they've done a really good job around improving outcomes and narrowing the gap. And they did that by a series of things, including protocolar changes to address clinician inertia. So one way is to say to clinicians, hey, you have inertia on clinical inertia on increasing medication, say, for patients with hypertension. You have more of that when the patients are Black, African American. You need to be aware of that. You need to correct that. And the clinicians can say, okay, yes, I'm going to be aware of that and I'm going to correct that. And that, it turns out, is not as useful as having protocols in place that really nudge the clinicians and nudge others in the environment to make those actual changes. So I'm not saying interpersonal versus structural. I'm saying interpersonal and structural.
Okay, thank you all. I'm going to go to the chat. I'm looking up, there was a question, I think a general question. Clinical care is often focused, but not limited to provider. We find interactions with schedules and other clinical care admins also impacts patient satisfaction. How do we consider all members of clinical team in mitigating bias and providing optimal care?
Can I jump in on that 1 second? So, my refrigerator's fixed. Thank you all. And so, and I think it's important to realize humans are humans, right? I echo Dr. Johnson's point earlier, where I have had to do some of the most obvious studies just to prove that the assumptions being made in the literature or the national discourse or what have you are wrong. You know, like a 7 cohort study of awareness is not enough. And so, and then we need to actually give people skills. So I think that you're absolutely right. On the question asker as well, the humans are humans. And so in our study with the patient focus groups in our initial study, they were talking about getting dismissed at the front desk. You know, a black man was talking about coming in straight from the office in a 3-piece suit, and the front desk is like, you know, kind of hold on, you know, they're talking on the phone, talk, and a white man comes up and they put the phone down immediately and they're like, "Hi, sir, how may I help you?" And it is infuriating. That's what his words were, and it's just additive, right? And in the moment, it's just, and then they walk in before they even see anybody else, and so. We have worked on changing the content. So pedagogical content knowledge theory is just a fancy way of saying you need to tailor the content to what people care about. And so instead of having a physician encounter, we have a front desk encounter, right? We have a whoever, you know, I don't know, working with transport and perhaps assuming of different things. And so I think people, if they're given an actual easy, like tangible skill, right? Nothing esoteric, nothing fancy and sciencey for anybody really. I like it easy and simple. People want to do the right thing, right? We want to do the right thing. It's just a little, it's sometimes it feels like a moral indictment when we mess up in some of these areas. And so we're a little more hesitant to dive in. But, you know, you read EK as an internist, I'm sorry, you read electrocardiograms over and over and over in medical school and residency, and suddenly those squiggly lines make a lot of sense. But you never save someone from a heart attack just because you're aware of electrocardiograms, right? And so I think that we all just need to partner to make it a team effort. But yes, every patient-facing human basically is probably part of the team.
Perfect. I'm going to take another from the chat, which I received by direct message. So what are the most critical gaps in our current understanding of how interpersonal bias exposure influences health outcomes in clinical settings? Part 1. Part 2 of that question, how can future research address the gaps that you offer? So most critical gaps and how interpersonal bias affects health, and then how can research address the gaps?
One thing I think is important is to actually test, for example, going back to the example of underuse of interpreters. One thing that I think is important is for research to actually test the comparative effectiveness of different strategies. Is it really about, like, for example, some units are putting, in pediatrics, this is happening a lot, they're assigning an interpreter to an area. Other places are forcing documentation. You cannot continue. Other places have put in iPads next to each part of the bed, next to each hospital bed, with an easy link to interpreters. Others are scolding the clinicians, which, we we did for many years to not a lot of impact. And so the question, I think, is what are the comparative effectiveness of different strategies or bundles of different strategies, and how does that work? And that, I think, is a very important study that needs to happen. So that's an example of where research can say, okay, how do we actually get to the bottom line? Similarly, if you take a particular clinical problem, underuse of knee replacement therapy, whichever well-studied clinical problem, how can a bundle or a particular intervention, to what extent does that close the gap? So I think we need comparative effectiveness applied research, and that, I think, is different from description. It is different from attribution. It is really in the world of implementation science. And I think that people who care about health equity, healthcare equity, which is what we're discussing, we really need to be pushing NIH and other funders to do more implementation science around equity.
I'll agree with Dr. Fernandez and, saying that we know implicit bias exists. We know that implicit bias impacts our patients in various different ways that we've already learned about and we'll continue to talk about throughout this 2-day workshop. But where the biggest gap is what interventions are most effective at reducing the impact of bias on patient care and outcomes. And I think in addition to thinking about this implementation science approach, an underutilized approach is thinking about patient safety and quality improvement approaches, right? So, we know that the principles of quality care are care that's safe, timely, efficient, effective, and patient-centered. But there's another E that's often forgotten, and that's care that's equitable. So how do we center and elevate the voices of patients and of families in helping us to develop and test interventions aimed at closing the gap in some of these patient quality issues that also happen to be equity issues? And how do we really center the margins and center the most vulnerable populations in our interventions? And so, every children's hospital is doing patient safety and quality improvement work. I imagine that is also true of, most other academic medical centers. And so how can we utilize that methodology with an equity lens and a more patient-centered lens to test interventions in a way that is a lot more facile than your traditional research methods as well?
So I hear being flexible with the research methods, especially considering the clinical environment, like what can actually be done and to get the best results. Dr. Velez and Dr. Gonzalez, I have a second question I would like you all to respond to. What are the opportunities, both practical and scientific, available to make progress on the clinical science of interpersonal biases in relation to health?
I need you to repeat the question because I was like, practical is science, and then I.
Okay, sorry. What are the opportunities, both practical and scientific, available to make progress on the clinical science of interpersonal biases in relation to health?
Dr. Bell, I've been talking a lot. I want to mute or I don't want. I'm going to defer first.
No, please.
Okay.
Yeah.
Thank you, Dr. Penway, for repeating it. So the opportunities to conduct the science and improving the clinical.
Practical and scientific opportunities. Yes. Mm-hmm.
So I think that if this isn't answering, just stop me. I think that there are. So it's all science, right? I do education science. I'm an interventionalist. My innovations happen. My intervention isn't a pill or a device. It's education, but it's intervention. And so I hope that's practical enough. And so I think that I think there's a couple of different things. I think we need to test the interventions. We're testing them on skills-based interventions in simulation because we don't want to do harm first to already harmed populations. I even think once we figure out how the right mix for the interventions. We should practice in simulations with which the pandemic showed us we can do on Zoom. You can actually weave in through. You don't need to have everyone come to a sim center and take a whole day off clinic, etc., or an emergency room shift, etc. And so I think that there's opportunities for micro practice, right, and small digestible chunks of skill building. We even played with the idea of having standardized patients that have office hours, because we did work where standardized patients were blinded to the purpose of our research. They're phenomenal at doing what they think they're doing and so dedicated, but they're blinded to the purpose, and we actually can approximate the patient perspective and that dyadic relationship, as was mentioned earlier. And so I think that micro practice, and also as leaders, we can foster a growth mindset and an ability to be able to make mistakes. I try to be brief, and Dr. Velez, I'll pass the mic to you in 1 second. Is that when we have a clinical conundrum, we all lean back and you're like, hey, I got a guy, or I got a patient, I got something. I used to call it I got a guy consult, but I have to be more gender inclusive. And so it's that I've got a patient consult, and whoever's not that busy in the hospital's room rolls their chair over. And they run the case by them. I love being the person that rolled her chair over, and I love when someone rolls their chair to me, right? And so why can't we do that for instances of bias and not just difficult to change organ failure? And so I think those are two, both practical and scientific ways of that are very tangible to try to affect change.
Thank you, Dr. Gonzalez. I think that was a really important point. Like I said, I'm speaking specifically about the psychotherapeutic context, where after professionals become licensed, they're often practicing independently, or even if they're in sort of like a group practice context, their work is not often being observed by others. So I think they're changing our models to have, I think supervision is one of the best aspects of psychotherapy training, and the fact that people don't continue to get supervision after they are licensed, unless it's a critical case consultation, is unfortunate. But that is one avenue that I could see regular surveillance or monitoring of people's of what's happening in psychotherapy being improved. But I think going back to what I said previously, routine assessment of clients or patients' perceptions of what's happening in psychotherapy is really important. Research indicates that clinicians' perceptions of their own multicultural competence are not associated with clients' perceptions of their multicultural competence, which is troubling. So I think, and all else being equal, I think we want to privilege clients' perceptions of that variable. So I think the routine assessment of that is across clinical settings is an important goal.
Thank you. There is a question in the chat further up that I want to go back to, and anyone can answer. Two-part, what are the panelists' perceptions of providers' desire for and or appetite for assessing bias through training? And then how can researchers design interventions that are appealing for providers?
I would love to hear, I know that Dr. Gonzalez is doing a lot of this work, and I would love to hear her thoughts on that. My sense is that I work in San Francisco, which obviously is a very, not obviously, but is a progressive part of the country. And my sense that people's appetite for this has truly diminished. That coming out of the pandemic, there is just so much fatigue and care and a clinician burden and so on, that the thought like, you're going to make me do something more, you're going to invite me to do something more, I think it is really very difficult. We've had diversity champion sort of training, and in our institution for a long time, one of the things that is most stunning, perhaps, about that is that one, lots of people have done it. And second, it is overwhelmingly women, like 98% women, if you take out men who've had to do it because of their administrative role. And I just think that there is again, I'd like to hear from experiences from Dr. Johnson, from everyone else on the panel. But my sense is that there is a growing feeling that the evidence base for training alone isn't there, and that's fair. But second, there is just enormous clinician fatigue, burnout, etc., and adding this to the list isn't there. Very curious what others think.
I'll definitely agree with you, Dr. Fernandez. I'm also in California and also in a liberal area, and I think overall most providers, the very, very vast majority, want to take good care of patients independent of their race and ethnicity. But I agree that there's definitely a lot of burnout, and so sometimes we need to tie this into wellness. Like, how do you have greater satisfaction in the work that you're doing, which can create greater wellness in the workspace if you're able to improve some of this cross-cultural communication, particularly when you're working with diverse patient populations. I think it's also helpful, and Dr. Gonzalez definitely needs to weigh on this because I know she's actively doing this work, but how do we pair it instead of isolated implicit bias training, right? Which we, have already mentioned, there's, mixed literature on that, but how do we pair this work with everything that we're doing clinically, right? So, Dr. Gonzalez mentioned, like, we have to work on reviewing EKGs from medical school through your entire clinical practice. So how do we tie in, when we're doing that work on learning EKGs, the disparities in who gets EKGs and who gets certain workup and evaluation for chest pain, and the role that bias plays into that. I just did a session a couple of weeks ago with my residents on the management of sickle cell disease. And so while I talked about acute pain crises and I talked about, strokes and all the complications of sickle cell disease, I also talked about stigma that's associated with sickle cell disease and how we can transmit stigma in the electronic medical records, as well as bias and kind of how we communicate. So I think it's important that this equity oriented work and this bias training work becomes more cross-cutting and integrated in all of the other work that we're doing, because of the burnout that we have around this issue. And I have explicitly heard people say, like, oh, are we done talking about racism yet? We'll be done talking about racism when racism doesn't exist anymore. But I think these separate discussions people don't want to engage with, so weaving it in with all of our other clinical work that we're doing is important. That's your cue to talk about simulation, Dr. Gonzalez.
Right, Dr. Gonzalez, are you
I'm talking so much. I just want to leave space for Dr. Velez. I'm sorry. Okay. Thanks. That's my cue to talk about simulation. So a couple of things. Yes. So this used to be really hard. I started my medical education research fellowship in 2010 when I did every homework assignment I could about implicit bias, because I just learned about the concept. And people used to lunge across tables at me, accuse me of going on a witch hunt in New York, right? So and then it got a little easier, and then it actually got harder in 2020 because after 2020, during and after, because what we found, and Dr. Fernandez and Dr. Johnson have touched on this, is that so many people with good intentions, right, and also some trying to profit, but we'll leave those out of the discussion for right now. So many people with good intentions recognized newly that there was a problem and did not partner with the scientists who had been working in this field forever, and presented programs that the rigor is outstripped by the good intentions, right? So heavy on good intentions, not so great on rigor. And so I used to go from being ready to bob and weave when I talked about implicit bias and that as my area of research, to having people roll their eyes in 2021 onwards and be like, really, I went to one of those. And so I think what happens is we have one-off encounters, right? We have one-off sessions, just like we don't do one session electrocardiograms. I'm going to stick with that example for the rest of the time. And then we have proven, we have published the brilliant conclusion that you cannot do this in one session. And so, wow. and with the water is wet study, Dr. Johnson, I did one of those. And so people are frustrated because most people only get to awareness, maybe a little bit of reflection. And so that if we could, I actually still believe, I can tell you exactly when I'm going to retire because I know the outcome that I need to hit before I retire. And I honestly believe that if we can help people with actual skills in an easy, not that time burdensome way, people will actually want to do the right thing. But if you keep telling me that I'm doing something bad and I'm hurting patients and I just need to go out and be better, I don't want to. I'm probably not going to engage, right? I'm just saying, I, the physician, Christina Gonzalez. And so I think that if we could see if people could see their skills growth in simulation, right, with interventions. Or if we can have those secret shoppers that a lot of people have unannounced standardized patients. I know Sandy Zabar and her group at NYU do a lot of the work. I'm sure many of your colleagues do as well. And people can see how they're getting better. Who doesn't want to get better at stuff, right? Like, why is racism and diversity and health equity the only thing that we're like, no, I'm good. And so it's I don't have a great answer beyond that. But I refuse to believe that it's not going to be possible.
I just want to say I agree wholeheartedly with you, all of you kind of speaking to it takes more than one training a year, but I don't necessarily know if probably more research is needed to know what is the correct cadence for, doing interprofessional bias in training. But I kind of think about it as a practicing clinician to, continuing medical education. Like, you don't just go to medical school and don't, continue your training throughout your career because changes are happening all the time. And the same applies, I think, to this, interpersonal bias training and other types of cultural competency. Dr. Fernandez, I saw your hand go up briefly. Okay.
Yeah, no, thank you. I think that given the current environment that we're all speaking to in terms of at least the two Californians are speaking to, and I think you are as well, Dr. Gonzalez, the sort of like, I did that already. I think it's really important to marry DEI training or anti-bias training, implicit bias training, to structural issues. I think that more training is not needed. More change is needed. Actually, that may not be true. More training is needed, but not in the sense of training alone. I think we have to marry training to structural solutions. And one of the things that I'll give as an example is that early on in the HIV epidemic, there were some studies that showed that people had that many clinicians had biased views of men who had sex with men. And then as they underwent their training, for example, residency in San Francisco, and got more experience, they treated people better. But lots of their views didn't change. And then over time, their views actually changed for at least some of them. And I think we've all recognized that long march. And so I think right now we need to be treating people better. And that we need to do that either because we've changed our minds or because the structure encourages, nudges, forces us to do it. And that is where I think the field needs to go. What is the right marriage of training on interpersonal biases with what combination of structural solutions? And then perhaps over a long time, minds will be changed. I don't go into this thinking we're going to change minds. I want to go into it, I would like that, but I want to go into it thinking we're going to change behaviors. People are going to get the care they need, irrespective of what that clinicians' viewpoints are. I hope that was clear.
Can I just add something real quick to Dr. Fernandez's point? Is that a multifaceted approach is definitely necessary, and I think it's a both and, right? Like I will just speak for myself, but my lab focuses very, very much on the interpersonal encounter, and the individual behaviors in that dyad. So I guess not individual, but the dyadic behaviors. And so I think that, but when you have a patient with congestive heart failure, right, their heart's not pumping that strong anymore, you've got the electrical the cardiologist, the pumping cardiologist, you've got the blood pressure cardiologist, you've got a bunch of people on board. And I think that often issues around health equity are held to this higher standard of this reductionist, like, well, you can't do it in this one thing. You know, somebody published a paper about should get rid of implicit bias trainings and use that time to address structural racism. Honest to God, if you can do that in 2 hours, by all means, you can have all my hours. If you can dismantle structural racism, have at it. Like, but it's a multi, and I understand where they were going with, but it's a multifaceted approach that I think we commend other fields for having, right? Team science and cross collaboration. So I think that I just don't want to lose that focus. And I agree with Dr. Fernandez's points for sure. And I just want to kind of highlight that it's a wicked problem, and we need very creative, multi-pronged solutions.
I also just, if I can have a minute to add on to what Dr. Fernandez said, and in agreement with everything that's been said. But, you know, I think when we think about the biggest issues that have impacted this country in terms of race and racism, we had to change policies before we changed hearts and minds. So yes, it definitely has to be, you know, a multi-pronged approach, because you have to do both. But, you know, when we think about, you know, parents didn't just agree, yeah, I want Black kids to be in school with my white kids. They had to change the policy, and then eventually I think most hearts and minds have changed as a result of it. But that structural level piece is important, and it always is the both and. But I also just want to highlight when, you know, Dr. Fernandez mentioned, you know, thinking about the times that we're in, also recognizing that, you know, we are fortunate that we live in California and New York and these more liberal places, but some of our colleagues are living in states where DEI work is actively under attack and has been made illegal, right? So does this work still need to be done? Absolutely. But we also need to think about more creative ways for doing the work so that it's called something different other than maybe implicit bias training. So how do we code switch? And, you know, it's, you know, for me, I think about, you know, my ancestors who wrote messages on quilts to write the maps for the Underground Railroad. And we essentially need to start doing that now for my colleagues who are in states where this work has literally been banned. It must continue. But we need to find different words to use to describe the work that we're doing as we continue to do it. And then, as you know, one of the earlier questions were on, like, what are some of the practical things? And so, you know, particularly for those of us, since this is the clinician's perspective, for those of you who are clinicians, think about what are those practical things that you can change from a structural level in your environment. So, you know, it was mentioned that it's not just the physicians, but there's multiple other points of contact that patients have in a healthcare setting. So, for example, at UC Davis, you know, we know that there's lots of bias related to pain management in Black patients. We know that there's lots of stigma related to sickle cell pain management. So sometimes we see that when they get triaged, they may get assigned a lower triage acuity. They sit in the waiting room longer. So we change the policy so that all patients with sickle cell disease coming in with pain are automatically giving a triage acuity 2, which helps us to get them in sooner, which helps take away the nurse's bias. Similarly, you know, we have a protocol where we activate a medical emergency for any patient who has a central line and fever, but we also recognize that patients with sickle cell disease who have fever are immunocompromised, and our oncology patients were being seen and getting antibiotics within an hour, while our sickle cell disease patients were waiting hours and hours and hours to be seen. So we changed the policy so that our sickle cell patients with fever are also activated. So those are just two, like, really practical examples for how you can think about within your clinical environment. First, do the water is wet study, right? And figure out what are your areas where you're having problems. And then when you identify those key areas within your clinical practice setting, as you work on bias training and anti-racism training, also figure out what are some of those practical local hospital policy-based things that you can do to improve the care for these populations.
This is great discussion. I'm really enjoying it. You all, I keep referencing my question list, and you're already answering many of the questions we had. So I'm going to go to, I was sent a private question, but then someone also spoke up in it in the chat about accountability. So with these, interpersonal bias training, what are some ways that health systems can actually hold providers accountable for actually putting into practice the skills that are taught in the sessions? Someone mentioned instead of just having it a checkbox like most of the other trainings, check annually, I did my bias training, so I'll wait until next year. So what are some ways that actual putting into practice the skills learned can be assessed?
I keep talking first.
We love to hear you talk, Dr.
You,
Gonzalez.
you know a lot about this. You actually you study how we can actually implement and evaluate this.
Okay, thank you. I keep watching all your mics. I'm like, are they still? Is nobody? No one's unmuted. Okay. But thank you. So may I offer the suggestion that we find new wording, which I can't do right now off the top of my head, about not holding doctors accountable, right? It just sounds so punitive. But fostering opportunities to demonstrate enhanced skills or success or something, right? Because I was putting in the chat about celebrating success. My colleague, Dr. Monica Lipson, talks about, I was talking to her about something, and we're talking about at Columbia, they have like a positive shout outs about good things that happened that were related to implicit bias or maybe explicit bias. I don't know, but I thought that's beautiful, right? And so I think about, but how do you actually tangibly do it? There's a couple of ways. There's the secret shoppers. They're called unannounced standardized patients, but a lot of us know about that secret shopper concept, right? And so they're trained actors, and they go in and they present a certain way, and then they evaluate assess the individual physician. And you can see you can make sure that there's certain things built in that may be more likely to precipitate that reliance on heuristics, as Dr. Johnson was saying, right? About that, those cognitive shortcuts we take, those conclusions we jump to. They you don't know when they're coming. You sign the consent, but they come whenever they come. Okay? You can do that in almost any setting, probably. I'm sure there's a few you can. But there's also, I'm very excited by the opportunity for AI. Stay with me, I promise it gets better. So my lab has spent tons of time on our wonderful team in very tedious, time-consuming research, analyzing verbal and nonverbal behaviors, like pouring through transcripts, and it's torture. And so, well, let me not diminish people who have actually experienced torture, but it's really hard. And so I think that what's really important is that the models now can be trained on dozens of cases as opposed to hundreds or thousands of cases. And so I know that Dr. Molly Rubin is doing some excellent work on facial recognition, and that's part of the facial like expressions and how you're taking care of patients with pain. And you can imagine if you have a patient with sickle cell disease that Dr. Johnson was mentioning, and my face is like, looks like I'm not believing you, you might wait a lot longer to see me to seek care next time with potentially catastrophic effects. Okay? And we may not even be cognizant of it. I feel like most people aren't like looking at you that kind of way, right? On purpose. But they are, and we are looking at patients in certain ways. And so I think that there's the opportunity to set up the simulations and study them and look at actual patient encounters in real clinical settings and be able to then target the high yield verbal and nonverbal behaviors that we can then teach people about. And the reason I mention AI is that as much as I'd love to keep winning money from the NIH, it's going to be super expensive to do it with all humans. But what I'm heartened by is the opportunity for note taking by electronic health records. Has anybody heard about this, where they can listen to the conversation? Some magical machine listens to the conversation, and with generative AI starts your progress note. That might be more trouble than it's worth. I have no idea. But what I am thinking about is it possible then, if we have enough encounters over time informed by patients, that we can then audio record encounters and then be able to give near real-time feedback, right? To physicians, almost like a coach, and so I think the next 5 to 7 years are going to be expansive in that assisted with technology ability to actually show we're making a difference. But in the meantime, I think secret shoppers, patient surveys. I was trying to ask about Press Ganey. Some people have had ceiling effects. I think we need to tie it into anything that affects the money, right? Because if something affects the money, then to Dr. Johnson's earlier point about policy changes, the health system will want to do something. You know, I heard somebody, and I get so upset because I can't remember who said it. They were brilliant. They said, "Why don't we only ever talk about cost when we're talking about black people getting the care that they should be getting?" Right? And it's a horrifically sad reality. But we need, and I'm not saying it's right, but since it's the reality, if we can partner with our health economist friends and try to conduct the economic evaluations, right, and show that you don't have to care, but you will save money, and facilitate those who do care to be able to make the difference.
So can I add on to that, since Dr. Gonzalez brought on the money issue? So when we think about, like, you're talking about it from a healthcare system, from an individual provider system, you can think about the money as well. So can we think about things like recurrent audit and feedback, where data is stratified by race and ethnicity? So in my previous institution, when I was at CHOP, the Children's Hospital of Philadelphia, part of my bonus was based on quality metrics, right? And so they identified key areas for the year, like the number of head CTs, unnecessary head CTs. And, so if we identify key quality metrics, based on the major issues in your system, and stratify data by race and ethnicity. And if your bonus is tied to you not having inequities in the quality of care that you're providing, I guarantee providers will be highly motivated to reduce some of those inequities. So, I agree that, we have to think about, especially in this setting where Dr. Fernandez already talked about just all of the burnout, how do we align, our incentives with things that are important to people? And unfortunately, or fortunately, money is one of them.
I'd like to, I'm sorry, Dr. Penwhite, did I interrupt you?
No, you didn't.
Okay. I just want to say, along the lines of what Dr. Johnson was saying, which I totally agree with what both of them said, but I want to caution people from using patient satisfaction or patient metrics because there is unfortunately so much bias. We've published a paper looking at how how different clinicians by gender and race are scored by patients by race and by gender and race. And unfortunately, for example, Black physicians tend to be scored less well by their white patients than by their Black patients. And because there are a lot more white patients than Black patients, at least in many health systems, that can drive down people's scores. So I do think I really just want to caution that when we do think about how to use, we should be very intentional and thoughtful and do research around what metrics to use to gauge how physicians are doing, and think about which patients and which metrics we want to use. For example, this issue of did you actually get the head CT or did you not get the head CT is a very different metric and not subject to the same biases as I don't like my OBGYN doctor because for women frequently score down their OBGYN doctor. Perhaps more research is needed to figure out why, but perhaps because they have different expectations.
Thank you. Our time is quickly winding down, so I do want to ask one final question and ask everyone to provide a brief response to it. So what recommendations do you have for next steps for the clinician, from the clinician perspective, to mitigate the influence of interpersonal biases on health outcomes? So if you could have your one wish today, what would that be as a next step in this space? Let's start with Dr. Velez, since you've been kind of quiet and taking everything in.
Yeah, well, I feel like I've learned so much, and I think my training is a little bit, and my practice context is a little bit different than some of the other panelists. But I think in answering the question, I think I feel a little bit less drawn to like the clinicians' perspectives about what needs to happen. I think more research from clients or patients on their perspectives of like what they would like to see in the care that they receive feels relatively more important. Parts of me feel like we've kind of plumbed the depth of understanding clinicians' perspectives for many topics. So to whatever extent we can have more client or patient voice, I think that is always a good thing.
I have one wish. I think there are a lot of NIMHD people here and hopefully people from other NIH institutes. I wish NIH would fund implementation science research around how to decrease, how to improve patient outcomes by things that combine training with other changes within the healthcare system. Thank you.
Since Dr. Fernandez had a wish related to money, I'll add another wish related to money, and that I wish that health systems would invest the money into addressing bias and discrimination and inequities in care with the same fervor that they put in other issues. So just as important as you want to have no adverse safety events for however many days and no Clab C infections, I would love for them to put those resources and that attention to, we want to have no events related to bias and discrimination and inequitable outcomes for our patients.
Ooh, and if not, no events, no negative impact, right? Dr. Johnson, like, oh, it happened and we had skills and it was fantastic and that's great. You actually are predicting my time of retirement. We have those bulletin boards of implicit bias, like just like we do Cowdies and Clapsies. My wish is that yes, if the NIH would fund intervention studies, would make me so happy. Or continue to fund. You funded some on implicit bias and trying to intervene rather beyond identifying and intervene. The other wish I have as a one on an individual level is that we would all develop a verbal procedure, is what we call them in my lab, and to restore rapport when bias is perceived. So when you can tell that a patient changed, that you can just take a leap and say, hey, I'm sorry, I seem to have changed a little bit. Can we pause? Did I say something? Something like that, whatever the encounter is. But and practice and then get a bias buddy and debrief. Done. So I see the clock staring at us. But yeah, verbal procedures.
Wonderful. So I will just summarize these last points. So next steps, or you all's recommendations for next steps, is really centering the patient's voice. We do have a lot out there, centering the clinician's voice. So centering the patient's voice, what do they want? Funding implementation science research on improving patient outcomes, combining training and health system changes. So that's been a theme from Dr. Fernandez, like the training, but also the structural changes. So training itself is not enough. We need to take that next step forward. In the same vein of funding, Dr. Johnson talks about really prioritizing funding for interpersonal bias and health resources, et cetera, and the outcomes, the same way funding in healthcare system is prioritized for other outcomes and other concerns. And then finally, Dr. Gonzalez, I guess second, the funding for intervention studies, so not just explanatory studies, but also how to restore rapport. So having that voice when bias is perceived in that patient clinician interactions. So again, I want to thank all of you so much for joining the panel and, having such a lively and insightful discussion. So let's please give a round of virtual applause for our speakers. We really appreciate the insight that you all provided. And thank you to everyone who also asked questions in the chat. Apologies, we were not able to get to all of them, but hopefully in the discussion you were able to learn and get something to help out with some of the questions that you had. And so we're now at 3:58. We're going to take another short break and ask you all to return at 4:05 for the breakout discussion sessions. So thank you all again and enjoy the break.
Hello, everyone. Welcome back. Hope you are enjoying the wealth of knowledge that we have. And let me go ahead and share my screen here real quick. All right. Yes, so we're gonna get started here, and then people will go through their respective breakout rooms. For now, I want to introduce the three moderators in the three breakout rooms. So the first is going to be etiology. The etiology breakout room, this area will involve discussions about psychosocial and biobehavioral mechanisms and pathways linking interpersonal biases to health. So the two assigned questions will be, what are the current gaps in the understanding of biobehavioral processes linking interpersonal bias exposure to health outcomes? And what are some of the research opportunities to elucidate the understanding of biobehavioral processes linking interpersonal bias exposure to health outcomes? The moderator of the etiology breakout room will be Dr. Aruna Gojieni. She's a program officer at the National Institute of Minority Health and Health Disparities. The second breakout room is the methodology breakout room. And this discussions will involve about existing tools and methods for measuring interpersonal biases and strategize on ways to improve existing tools and methods, or to improve and develop new tools that more effectively assess interpersonal biases or their expression or impact on their behavior. And so the two questions here will be, what are the limitations of existing methods and tools used to assess interpersonal biases and or the influence of bias exposure on health? And what are the ways of addressing such limitations? The second question will be, what are the opportunities for developing new, more effective methods and tools to assess interpersonal biases and or the influence of bias exposure? And last but not least is the interventions breakout room. So I should say that the methodology breakout room will be moderated by Dr. Olga Heron, who is a program officer at the National Institute of Minority Health and Health Disparities. The last breakout room will be the interventions, and this focus area discussions will involve multi-level interventions, so individual, interpersonal, community level, that addresses health disparities by reducing interpersonal biases, their expressions, or their influence on discriminatory behaviors. This room will be moderated by Dr. Karen J. Roberts, and Dr. Roberts is an NIH ACMG Fellow for Genomic Medicine Program Management. And the two questions assigned to this room will be, what are the barriers preventing progress toward the intervention stage of addressing interpersonal biases or addressing the health implications of bias exposure? And what are the opportunities for developing effective, sustainable, and feasible interventions aiming to address interpersonal biases or addressing the health implications of such biases? So now we will go ahead and open up the rooms, the three rooms of your choosing. Please go ahead and we will be back and reconvene at 4:55. Welcome back, everyone. We hope that you had some stimulating discussions in your breakout rooms. So we're going to take the next 20 minutes to hear a synopsis of what was discussed in each of the breakout rooms, just to ensure that everyone has a chance to hear the thoughts that were posed by the questions by each of the breakout rooms. So let's go ahead and get started with the etiology group, group one, led by Dr. Gojineni. Aruna, are you available? Aruna, there you are.
Yeah, there I am. Yeah.
So go ahead. Do you mind giving us a synopsis of what's?
Yeah, I think the first question that we were, one of the questions, the first one related to etiology is, what are the current gaps in the understanding of biobehavioral processes linking interpersonal bias exposure to health outcomes? So some interesting thing that we're not really taking too much into account the socio-political context, and that needs to be factored in. We're not doing such a good job in this area. And there's, an example was provided of how we can create a composite score of connecting systemic factors to health outcomes. And also the need to rigorously develop measures of socio-political context was also raised. And in terms of the research studies, people need to be made aware of how socio-political context needs to be taken into account in interpreting the results. And these socio-political attitudes are important. They're macro level factors which are impossible to control for. And measuring them in a study, I think it's really important to focus on that. And another aspect that was discussed in that context is that currently there's a lot of anti-immigrant, bias going on, and even at the local context, it's spilling over. And to what extent are we measuring things like that? And the need to do that, and the need to bring in political sociologists into our teams, and that was also raised in the group. And also another issue is that we discussed is to what extent are we measuring physiological stress well, and what are some of the things that we need to look at tying in how interpersonal biases relate to physiological stress and health outcomes. So even though there's some work tying in chronic stress to, related to health outcomes, still there's a need for further research in this area. We do not know enough about all aspects of physiological stress, and we need to also have good measures related to that. And tied to that is the stress related to racism and how it differs from other types of stress. So that was there was a discussion about that. And another issue that was raised in our discussion was we also need to look at relevant covariates which might be interacting with the stressors. For example, taking into account air pollution when you're also teasing apart the effects of discrimination stress.
Excellent. Thank you very much, Aruna. And it certainly sounds like a very rich discussion, and one that it's definitely worthy of further speculation. Particularly, it is not just the measure of interpersonal biases that has not been settled. So as we know, there's certain challenges with measuring interpersonal biases, but there's also a lot of challenges measuring physiological responses to stress. And so it's important to really look at the opportunities that we have to better our existing methods and tools. And it's not just focused on the implicit bias realm, but more along the continuum, so to speak. So thank you for that rundown.
Sure.
Dr. Heron? Yes, go ahead, Aruna.
No, just one final thing on question number 2. There was also discussion about how intersectionality, the methodology in order to test that is underwhelming. And so mainly we're looking at scratching the surface by looking at interactions. And, tomorrow there's going to be discussion about the use of meta-analysis approaches and how that can be useful in being able to, look at or measure intersectionality. So that was another issue that was discussed.
That is really intriguing. I cannot wait for those discussions. Meta-analytic approaches, interesting. Excellent. So next up is Dr. Heron.
Hi there. So I had a lovely discussion with my breakout session. in terms of methodology, the limitations that we got to discussing, because many were already addressed by the previous talks. So the limited inclusion of populations and how these constructs are defined and measured across, between these populations and within them, that heterogeneity. And what additional factors are the most significant and impactful in addressing to result in improving health, not taking throwing the whole kitchen sink sort of thing. How to inquire and measure differences between and within providers and how they assess populations, and how these assessments may differ based on how persons from these populations present themselves. How to tailor objective observational techniques, and using data-driven, technology and methods to process and evaluate provider-patient interactions is just still very limited. And some of the ways of addressing these limitations were to develop better methods to measure heterogeneity by improving research investment in these populations that have been understudied and under-researched, including, developing like a taxonomy of different factors and how they layer to impact public health in that population in a meaningful and impactful way. Protocols that identify when to change a provider, that can identify interpersonal concerns, going towards that direction rather in mechanisms of why providers may differ and how they provide treatment. That's not, that does include bias, but may include other factors that impact how biases may arise. Objective measurements using informatics is another way to overcome some of those approaches in terms of observational techniques, in that they are, and then just trying to shorten it a little bit because we talked about a lot. Developing informed procedures for giving feedback to providers and tying it into patients' experiences and measurements, and doing the same in terms of like how providers can better communicate feedback to patients. And for the second question, which was talking about the opportunities for developing new, more effective methods and tools to assess interpersonal biases, and their exposure on health. Of course, AI, data science, and community engagement were the big ones mentioned. Incentives were a very, very big part of our conversation, and how to create incentives that are not just meaningful in a cash value, because we know the limitations with that, but also in terms of like cultural value or value outside, in terms of like knowing what's better for your community, or different things like that, and learning what those opportunities are. Studies and outcomes and benefits of participants are needed. Benefits of participation are needed to must be communicated. Adapting recruitment measures constantly to reflect the changing landscape. Being familiar and staying connected to the community, and trying to promote more relational protocols and training, so that way lived experiences can be incorporated earlier on in, in just even learning about health. And so that can be kind of just flow into think a little bit more. Opportunities that need to be made for more personal interactions, for workforce support and training on how to develop connections and relationships to better support data collection and, increase the value and the quality of that data. And so structural competency came up a lot in its importance in clinical and research expertise for developing opportunities, measures, and tools. And something that we noticed and talked a little bit about towards the end was the difficulty in standardizing language across disciplines, to be able to conduct the research and to be able to communicate these research perspectives appropriately. A lot, so I'll send you notes.
No, that's absolutely wonderful, and it certainly sounds extremely insightful. Also, the need for standardizing language across disciplines is critical. One of the main sort of barriers that I see making progress is that I just keep highlighting is the fact that these research just remains siloed in their own respective disciplines. In particular, social psychology, up until for the longest time, anything having to do with implicit bias was rooted and continues to be largely rooted in social psychology. And so it's not until now, and especially with initiatives like these, that we're now able to really spotlight the need for there to be multidisciplinary scientists and groups and teams to be able to carry this science forward instead of just in our own scientific islands. So
Absolutely. Real quick, that's why I said, that's why I mentioned structural competency, because there was even a discussion, like, what cultural competency includes, because some people do think it includes structural competency and some people see it as a separate thing. So absolutely, that's a good example.
Excellent. Thank you, Dr. Heron. And last but not least, Dr. Roberts.
Thanks, Carlos. We had a really robust discussion and looking at some of the barriers preventing progress towards the intervention stage of that addresses interpersonal biases or addressing health implications of bias exposure. So some of the highlights there, we had comments that this is a twofold barriers. There's the providers creating a non-inclusive process of health. Largely because the patient may not be involved. It's coming from the provider to the patient rather than potentially system not involving the patient. Also, a comment, a theme that kind of came out was when we're looking at explicit and implicit biases, those themselves are outcomes rather than how does that connect with health outcomes. So that would be, going beyond just describing the fact that implicit and explicit biases exist in healthcare, but then how do those impact and address patient health outcomes? We had some great discussion on from just experts who are actually really doing kind of implementation and interventions already. That their descriptions of barriers are making it relatable just in the language that we're using. The people are not vested in sort of what's happening, both from the patient side, they're not understanding, but then also, if I understood it correctly, as people are trying to teach about some of these concepts to providers of all different types across the healthcare system, those that are receiving that training maybe are not, they don't value that. They don't see this as a value. And so it was a great, I felt like a really great observation that rather than sort of blaming people for their biases and that type of thing, focus it on, we're here to provide the best care for the patient and this is how we need to do it. We're not going to change anybody's, we're not here to change anybody's personal biases or the way they think about things, but while we're here caring for patients and families, we need to focus on providing that best care. So I just felt that was a really insightful comment as centering patient and family, which I think we heard earlier in several of the other discussions today. Kind of tagging on to that, the discussion about equity is really about accountability and holding people responsible for their behaviors. So again, sort of focusing less on their own biases, but more on the behavior and then just that provision of care. Many people discussing some funding issues, how we can fund particular research, particularly implementation science, would be what are those opportunities to do that, and looking at, again, not only from the provider side of things, where seeming as, we're funding sort of provider interventions, but what about directed from the patient and the family side? So also looking at both of those different ways to intervene that, and who is, kind of that centered approach, patient family centered approach, as someone I think mentioned in the previous session about community participatory research. And then I'll just kind of skimming here, brought up also the importance of social determinants of health, but in particular, racism, looking at racism, measuring racism as a social determinant of health. And also, as healthcare professionals are trained those healthcare professionals from underrepresented or those who tend to experience more discrimination and bias, implicit or explicit, maybe not just from patients, but that how they are experiencing that in their training in whichever discipline of healthcare they're in, and how that impacts their own health, and then also kind of just continues to have ripple effects throughout the healthcare system. And again, Dr. Gilman took very detailed notes, so I'm hoping that I did justice with just sort of trying to give an overview of the main points, and certainly just to reassure those in the group that we will reflect everything that was discussed. So thank you.
Thank you so much, Dr. Roberts. Certainly a very, very intriguing conversation. It sounds like, for sure. Particularly one thing that I was taken aback, and certainly one thing that I truly think that we should continue conversing about, is the fact that it's striving to get people to put value in doing something about their interpersonal biases. I mean, most intervention-based approaches inform that it's critical for people to first realize that there are interpersonal biases, that there's a problem, and what that problem is, learn more about the interpersonal biases, to care about doing something about their biases, and then finally learning ways to do something about it. And so it is training people to really place value in striving to limit their expressions of interpersonal biases. I think it's pretty much key to moving the needle forward in finally neutralizing a lot of these damaging biases. So thank you very much for that. It certainly sounds like a very insightful conversation from all three groups. So I thank you so much for expressing your thoughts. So as we bring this first day of the workshop to a close, I wanted to take a moment to really express my heartfelt gratitude to everyone who contributed to making this today such a resounding success. So a big thank you to our esteemed speakers and discussants. Your thought-provoking presentations have sparked vital discussions and offered deep insights into the complexities of interpersonal biases and their impact on health. I would also like to extend my appreciation to the moderators. Your skillful facilitation and incisive questions have endured and ensured a fluid and engaging exchange of ideas throughout the day. So really, today has been a testament of the power of collective intellect and shared passion. So the dynamic conversations and the wealth of knowledge exchanged has set a high standard, and I'm deeply satisfied with the progress we made together. So as we look ahead to tomorrow, I'm excited to welcome you back for another day of rich dialogue and discovery. So tomorrow's lineup promises to be equally as compelling as today's, with a strong emphasis on research. So we will have 2 flash talk sessions that will highlight emerging studies and innovative approaches. We also will have 2 thematic sessions that will delve deeper into methods and tools in the study of interpersonal biases and into evidence-based strategies and interventions. So thank you once again for your participation and your contributions today. Let's carry this momentum forward into tomorrow as we continue to explore, learn, and advance our understanding of interpersonal biases and health. So you will not want to miss tomorrow. Have a wonderful evening, and I will see you all tomorrow. Thank you.